before I was involved with BioRESEARCH, Dr. Mike Smith saw this technology and just was impressed that it was objective information. And he has just taken these technologies and run with being able to understand what they're telling us clinically, being able to interpret, between the patient's history, this information, imaging, just the number of cases that he's been able to get his eyes on. Probably, I'd have to think of who has seen more. Yep, gotta get that. Yep, gotta get that.
You gotta get it for Korea, man. They're awesome. You gotta do something.
So between the number of cases he's seen and interpreted with this technology and his advanced knowledge with the laser, going to Venice, understanding, sitting down with Lucio, using it on so many different patients, taking he's developed these technologies like anybody I've ever seen, and that's why, he's our advanced instructor for these classes. So without any further ado.
Thank you, Nate. Yeah, it goes way back when we had to bring Nate out of diapers. And we had to teach him, what's going on with all the technology. He's great. He's a great asset to the company. And one of the best things I really want to compliment BioRESEARCH on is how forethought they are on promoting education and promoting excellence with the technology, because they sponsor a lot of different continuums. They sponsor education. They believe that when people embrace this technology and use it the right way and get the extra knowledge and apply it to their practice, they can make the biggest difference in the world for their patients. So I really am thankful that the company stands behind what they do with education and advancing the technology, advancing what we can do. So without further ado, we're all here today, right? We're excited to be here in this humdrum weather. There's no better place to be than inside today in Milwaukee, right? So we're happy that we can be here for that. So we're going to talk about a lot of different things today as far as concepts of utilizing the BioPak information. And I'm not going to spend much time on basic interpretation. There's other people who are going to do that. You've already learned that. You've already experienced that. What I'm going to talk about is how you're going to take this technology, see what it's doing, how you're going to apply that to a patient in your practice, and we're going to work up basically somebody here in the room. You don't know it yet, but I'm going to pick on somebody. And we're going to put you up and we're going to run through a whole series of tests to see what can you do, what is your baseline, what things are looking like, and what can we do to adapt, apply this technology to make it so it's going to work in your hands. I'm going to teach basically a philosophy-independent type of mode today. I don't care what philosophy you believe in. If you're a CR doc, if you're a neuromuscular doc, biophysiological doc, I don't care. What I'm going to do is give you the method to be able to measure your madness to make sure that you can get the best treatment possible for your patient. And we're going to utilize everything that BioPak has today. We're going to use JVA, JT. I'm also going to show you why the value of JT is. I love it. It's phenomenal. But I'm going to show you why we like to use it in these particular practices and how applying T-scan on your basic initial visit and when you should do that, when you shouldn't do that, and what kind of values you're going to look for the patient to get that under control, and how you're applying your EMGs and your MLS laser to get the best benefit as a diagnostic tool and a therapy tool in your practice. And I'm really excited about it because, I like to bring new horizons in to people when they start thinking about what kind of treatment you're offering, what you can do for your patient, and how you're going to assess the patient to get the best overall outcome for that patient's goals, wants, desires, and needs to be able to get them the best way we can in their new horizons. I want to thank my family because they let me travel all over the world to talk and embrace people about biometrics and advanced education and dentistry because I love dentistry. I'm passionate about it. I just love it. It makes me tick. It goes. I'm come from a long line of dentists. My whole family is in dentistry pretty much from years and years ago, and I love it, I live it, I breathe it, and I'm passionate about what can we do to change people's lives and make them better. And that's what we're going to talk about, being able to change people's lives, makes them better. I'm a third-generation dentist in Phoenix, Arizona. My grandfather started the practice in the early 20s, and so I've seen dentistry go a long different direction, a lot of different ways. And my sister joined me in the practice about 7 years ago, and she just does ortho. So I have a unique ability now that I don't have to send ortho out. I can do ortho in my practice. And I'm going to tell the camera guy, I'm going to drive you nuts because I am everywhere, and I'm going to be all over the room, and it's going to keep you from falling asleep because I don't want you to fall asleep. So you're going to follow me around because I pace, I wander, I move all around. So have fun following me. This is my practice. I'm a third generation general dentist in Phoenix, Arizona. My practice is a general family practice with the emphasis on comprehensive aesthetics, contemporary restorative, and cosmetic rehabilitation. I have a large pain management and TMD and OSA practice that I've developed throughout the years. Now, you can do that in your own practice as well. It's very simple. Use with what you got inside your office, use the technology, and build from within. And it works really, really well to do that. We've added ortho for adults and kids, and I do have to put a caveat in there. I do own a removables lab that makes specialized appliances, orthotics, and customized splints. So I do make money on this, and I do recommend it. I love it. If you want information about the lab, I have cards up here that you can look at, and we make all kinds of specialized TMD orthotics. If you dream of something, I can make it. Just let me know what you dream about. So we're going to talk about these concepts today of how patients come into your practice. Okay? They come in for a lot of different reasons. They come in as far as general practice. They say, hey, I need to get my teeth cleaned. It's been a long time. My wife hates my breath, blah, blah. You know the whole story. I got to get in to get something done. We have patients that come in just for orthodontic concerns. They don't like the way their teeth are. They don't like their smile because they're crooked. We have cosmetic-oriented patients. You know, those went away a long time ago, and they're starting to come back because the economy's changed a little bit. So now we're getting patients that are more concerned on cosmetics again. So we do have a lot of that. And we have TM pain patients that come in to see you. Or you have a combination of patients that come in to see you. TM, ortho, they have everything that they're involved in finding out what their wants, desires are going to be. And we want to determine on all these patients that are coming in to see us in our practice, are they coming in and what is their condition? Are they a normal type of a joint muscle type patient, or are they abnormal in any kind of way? Are they in an acute phase or a chronic phase? And where are they? What do they want? And what are we going to go about treatment-wise for them to get them healthy? And a lot of times these patients have a desire. They have a want. They have a goal. They come in to see you. They say, Mike, I chipped this tooth, and I'm having a hard time eating because my teeth are getting worn out. And they have a desire to get something fixed. They think it's a functional nature or a cosmetic nature, when they don't realize it's a complex nature where they have a joint problem, a muscle problem, a breathing problem, and they have all these things that are going on that you have to figure out what's happening for them in your diagnosis, and they can take that one goal that they have and change their goal set after you work on with them as far as education of what's present, what's going on, and what do you need to do to fix it. And so a lot of times their goals may change after you start presenting to them of what do you see and where they are. And you know, how many of you get this question? It's like, I don't know, doc, you're the expert. You get that, right? When you ask a question? And I like to turn that question. When they ask you that question, I like to ask them that question back. And when I ask the question back, I say, what do you really want? What are you here for? What are your short-term goals? And what are your long-term goals? And how are we going to apply you now and in the future to keep you healthy and make you look as good as possible? So don't just say, oh gosh, you know, you hate that question. Embrace those questions and ask them another leading question to get a desire of what you're trying to do is to help them out to get them as healthy as you can. But the biggest thing about asking these questions is understanding the why. Why are they here? What's going on with their why? What's going on with their what? What's happening inside their mouth, their complex, their jaw joint, their muscles, their teeth, their airway, their ability to smile, their ability to eat, their ability to choose. Understand the why before you get into any kind of modes of treatment of let's do this, this, and this. Because this is the most important thing that we have to ask the patient is why are they here? How did they get there? Why did you get to this point? Why are you seeking treatment now? Really important things because they know you got this problem that's going on for a long time. What's changed in your mindset to say, why do you want to get treated now? You've been this way for 10 years. Why? What's changing in your life? Because if you can get some of the whys, you're going to get outstanding results with their ability to say yes. Because if you can understand the why, the yes comes really easy to get it where you can get them to be healthy again. So when we're talking about our biometric evaluation, we have lots of things that we're going to look at with our treatment decisions. But we first have to understand and establish a baseline towards treatment. A baseline of where they are now so we can start understanding the why. So a really important part. This is huge because if we don't have the ground roots of where they are now, we're not going to know what to do in the future. This goes with everything that we have in our patients that come in our practice. We've got to have an accurate baseline. Our restorative care patients, our general care patients, our cosmetic patients, especially our ortho patients that are coming in, that little Johnny needs his teeth moved because he needs to be able to smile, eat, chew, and function because they're all crooked. But we got to understand what the baseline is before we start moving things around, or we may lose direction further on down the road. So we've got to find out what's going on. And to establish that baseline, we're going to use several things. Our joint vibration analysis to look at the joint. We've got to understand what the hard and soft tissue is doing with the joint. Our jaw tracker, what's going on with the range of motion, their velocity, their ability to open and move their jaw in a normal type of a function, or are they abnormal? But our range of motion issues, we're going to use our jaw tracker for. Understanding what the muscles are doing in rest, what the muscles are doing in function at baseline. Where are they now? If we're having issues with occlusion, is the occlusion affecting the muscles? Is the occlusion affecting the joint? What's going on with the way the teeth come together? And then our clinical assessment of how things all fit together. What does the soft tissue look like? What does the hard tissue look like? What does the airway look like? All the other aspects that we need to look at to put the pieces of the puzzle together to establish where are we going with this patient to get them healthy. And we got to get a starting point before we start active treatment. Huge important type of a thing. We need to know what the patient's history is before we're getting into treatment. Because, and I got this from Chris Stevens, is the mysteries in the history. That once you start asking certain questions, you'll start getting different answers. How many people ask their patients about trauma? If you see an existing joint problem in a 30-year-old female, 25-year-old female, 40-year-old female, a male at any age, do you ask them about when did you have your accident? They have a unilateral disc displacement. They have something going on inside the jaw joint. You can see a little asymmetry. How do you ask that question to the patient? I don't ask, it's like, did you ever have an accident? Because they're going to say no most of the time unless they visibly remember it. I ask the patient, when did you have trauma to your head, neck, or face? Because they look at me differently that way. They don't just deny it. They look going, I don't know. I don't remember. Did you ever fall and hit your chin when you were younger? Did your brother trip you and you hit the coffee table? What kind of trauma did you have when you were younger? I don't ask if, it's what kind of trauma. Because I already know they had something there. If they had a skeletal deformity and I already see an initial joint problem, I already know they had some kind of trauma down the road. They might not remember it. They may or may not. But it's important to ask the question the right way. And I got to determine what that patient's chief concerns are now. What brought them in to see me? Why are they here now? What are your chief concerns now? Because this may change a little bit once we start talking to the patient, putting photographs up on the screen saying, this is where you are now. Do you like your smile? They said, well, I thought my smile was great until I looked at that picture. Is that really me on the screen? And I get that a lot. You put their picture right up in front of them on a big screen TV and they look going, who's that? That's you. No, it's not. Yeah, that's you. That's a picture we just took of you. Huh. Does it look that bad? Well, it doesn't look that good. What do you want to do for your smile? What do you want to do for you? It's an important part. But this chief concern may change once they start seeing your process of going through your exam and your diagnosis. And what are their immediate expectations? Now, we're in this age now where people want immediate results, right? They want fries with that. They want something now. They want to see a benefit now. They don't want to wait. We're in the I want it now phase. We have to find out and understand what their expectations are, immediate gratification. What do they want? Like our pain patients that come in. They go, I'm in horrible pain. Okay, great. Where is your worst area of pain? And they point. And almost always they say, it's in my jaw joint. Right here. See? In my jaw joint. And you go, oh, great. You already know it's a muscle problem. I'm not going to chastise them and say, no, idiot, that's not your jaw joint, that's your masseter. I'm not going to do that, but I'm going to say, oh, okay, great. I just want to understand where you're having the pain that's in your jaw. I'm not going to say your jaw joint, but it's in your jaw because it's a muscle mastication. This is their closing muscle, their masseter. I want to know where it is because those patients that want immediate gratification, I can get my MLS laser out And I can treat that trigger point, that hot spot of that muscle, and I can turn it down, and their expectations change a little bit. They go, wow, I've been to 3 other people and nobody could address my pain right now. I want to address your pain. I want to address your concerns. I want to make sure that you get immediate gratification so you can be comfortable. I want to get that immediate gratification under control so I get treatment acceptance. I want them to say yes now. I don't want them to say, no, let me go home and talk to my spouse. No. I don't want them to say, let me go and get another second, third, fourth, fifth opinion. I want them to say, wow, nobody's ever been able to address my chief concern now. I want to start. I want to get treatment done. And that's getting them through their immediate expectations of finding out what they want. What's their extended goals? Extended and immediate goals sometimes are different. But you got to ask. You got to see what's going on with that. And what type of treatment are they looking for? This is hugely important when you're talking about comprehensive care. You know, because a patient comes into my office, we don't just say, well, we're a tooth fix-it by day kind of a thing. I'm not going to do what your insurance is going to pay for. I want to look at everything in total. I want to see the whole big picture of what things look like on you. Comprehensive care. What can we do for your whole package to get you healthy, keep you healthy, and looking the way you want to look? But some patients' expectations of what they're looking for is different than what you think optimal is going to be. Because they say, no, I don't mind losing my teeth and going to partials. I don't mind having a space between this, this, and this, but I just want them healthy. I want to be able to chew, eat, and function normally. I want to get rid of the pain from this tooth that's broken, or I want to be able to sleep better at night. But you got to find out what they're looking for so you can design the treatment towards their wants, desires, needs, and goals, and still be able to hit a home run and treat all their pathologies that they're looking at. We need to also determine out what kind of achievable options that we have for this patient. What can we do with the pathology that they have? Is it reasonable or not reasonable? Because some of these patients come in with unrealistic goals. You know, they come in and they have horrible perio problems. You can smell them coming through before they get into the parking lot, and you can smell that perio breath, right? You know what that smells like? Who had a person on the plane that had perio breath coming on in here? Isn't that horrible? It's like, can you take your dirty socks off and stick it in their mouth so they get some kind of relevance of what they're doing to everybody else? But yeah, it's horrible. But understanding what the realistic goals are for that patient. You know, they come in and they have a horrible situation. Then they go, I want to have this movie star smile. And you look at them and say, 10 years ago, we could have achieved that. But right now, we may not be able to because of the existing pathology that's going on in your jaw. Some patients come in and their whole thing they're coming in for is they go, I don't like the way my jaw pops and clicks. Okay? Well, that may be an unrealistic goal because I may be a noisy doctor, but I'm not a noise doctor. You know, because I may not be able to get rid of that entire click, that entire pop, because you have a permanent deformation of that disc condylar assembly where you've dislocated your jaw so bad over the years that you have some tissue that's torn, you have cartilage that's readhered, and you have adhesions that's making this noise that's present. I may not be able to get rid of that. I may be able to decrease it some, but I may not be able to get rid of all the noise. So it's important to find out what realistic expectations are for that particular patient and their goals of what's going on. And if you have to talk about unrealistic goals or what's possible, if you can talk about compromise early on, when you start getting your diagnostics and you get their goals and their expectations under control, if you can talk about what's possible and what's not possible for them, for their pathologies, their conditions, and their system that's breaking down, and you can say, this is where we can get to. You want to be here, but I can only get you here because of all the things that's going on. And you talk about that on the front side, you're not making excuses because you failed to be able to expedite their goals when you start going through treatment. So talking about it ahead of time that you may have compromise going into this because of where you're going to go. It's like when they bust their tooth out when they were younger and they have this big gingival defect, they got bone loss, they say, I don't want a bridge, I want an implant. And you know you can't bring that tissue down far enough. You say, I can rebuild this, I can put an implant because you really want an implant, but I'm going to have a little tissue height collar issue. And you know you can bring it down some with free gingival grafting and your bone graft, but you may not be able to get it just perfect. That's a compromise. Other compromise is noise. Other compromise is maybe they have a flare-up or periodic discomfort. You got to talk about what's possible for them and ahead of time of what can be done and what can't be done. Okay? I want to break it down. We talk to our patients so much about the process of what we learn. And we talk sometimes over their head, where we give too much dental terms, right? Where we go, oh, Miss Jones, you have a partially disc that's displaced on your right side, which is a Piper 3A. It's recovering when you open and close, so that's good news. They don't give a rat about that. They just want to know what's going on. So break down your dentalese. Start going back to normal English or Korean or whatever language you speak. Bring it down, make it simple, stupid, because you got to be able to talk in the patient's realm of where are they. Because if I start talking to a patient and say you have this disc that's displaced and you're opening and closing and it's reducing and you're picking it back up and they don't care. But you say, Miss Jones, you have this disc that's dislocating. Your jaw is dislocating every single time you open and close. Is that a concern to you? They go, yeah, because they understand what dislocation is, right? It's not a big dental term, it's a basic term. If you dislocate your shoulder, are you going to get it fixed? They go, yeah. Well, you're dislocating your jaw joint every time you open and close. Is that a concern to you? Well, what is it going to do long term? That's where you talk about the benefits of treatment, of what can happen if you let it go. And if you let this go, how much worse is it going to be in 5, 10, 20 years? Are you going to be able to open and close normally? Are you going to be able to function normally? Can you smile? I mean, those are really important things. And the other big thing about that is you've got to be able to breathe and sleep. So can you do that too? So break your dental ease down and talk in normal terms. And I'll go through and talk about a lot of normal terms of some of the conditions we talk about. Probably the number one thing I use on patients that have a disc problem that come in to see me for TM issues is you're dislocating your jaw. And they get it. They understand it. They know it's like, oh, I got to do something if it's dislocating. You've torn your cartilage. That's another really good one. They go, oh, that's bad. Yeah, that is bad. Because they know if they tore their cartilage in their knee, they're getting it scoped, they're getting it cleaned out, and they're getting it fixed. We got to find out what the fix for them is going to be. So talk about general terminology instead of really complicated stuff. We're not trying to impress the patient, just educate them on normal type of stuff. So when I'm talking to the patient, I want to talk about normal and abnormal joint. Do they have something that's normal or abnormal? And that's really all we're after when we're talking about the joint for the patient when they come in for their initial visit. Normal or abnormal? Great, we're normal. You have some cosmetic concerns? Let's fix it. Let's make you look beautiful. Not a big deal. That's great. If you have abnormalities, then let's talk about what can we do to fix it before we get into this other optional type dentistry. So it's important. And we need to ask the patient, talking about popping and clicking. Patients, how many, you'd ask your patient that question, does your jaw pop or click? And they go, yes. And do you ask them, say, is that normal or abnormal? Ask them that, see what answer you're going to get. Oh, Susie, my last hygienist, told me that it's normal because I've had it for so long. But it's an abnormal condition. It's a pathologic condition. But the thing is, they're getting confused with common and normal. It's a common condition, Miss Jones, but you do have a disc that's getting dislocated every single time you open and close. And they go, well, how come Susie told me it was normal? Well, we have technology now that we use in our practice so we can find out, is it normal or abnormal for you? And we need to monitor this. If you're not wanting to go through treatment now because you're unsure, because Susie told you this years ago, then we can monitor this over time with our technology that we have to see, is it getting worse? If your jaw starts to get worse, and we can measure that, is that something that interests you to get treatment done? Oh, it's going to get worse? That's the answer I get when I go that way. It's going to get worse? It has a possibility it can do that. If you want to start treatment now, we can do that. If you want to monitor this over time to find out, are you adapted? Is it getting worse? We can do that also. What satisfies you? But what I want to do is be able to take care of you before you have pain all the time. You mean I'm going to have pain all the time? That's a possibility. Patients get motivated by what? Pain, restriction, because they can't open, can't close, ability to eat, breathe, and what's the other thing they get ambitious about? Money. Because if you say, we can wait and treat it later if it gets worse, but if it gets worse, it may cost more to be able to treat. Ooh, it might be a selling point for them if they're really money conscious. If it's going to be more expensive later, maybe I ought to look at earlier treatment now. Because proactive care sometimes is the best care possible for the patient so they don't continue to break down and get worsened. So that's an important thing to talk about, popping and clicking. And I like to talk to the patient about popping and clicking because I want to hear their answer. You got to talk to the patient about their range of motion. Can they eat? Can they chew? Can they function normally? Okay, that's important. I also talk to the patient about history of locking. Because if the patient says this, what is the answer sometimes they say? Yes, my jaw used to pop and click, but it's better now because it doesn't do that. You hear that, right? So when I hear this, my next question after this, once I do a little bit of my spiel, is, did your jaw ever used to lock? Oh, yeah, it did. And then it used to pop really bad. And now they have a problem with this. So it's kind of your history, but it's getting them educated on their history that, yeah, because it was popping and clicking, it was getting worse. And it worsened to a point where it did lock, and then it self-resolved because it worsened even more, and you broke more tissue away, and now you have a disc that's permanently dislocated and not coming back on, and now you have a range of motion and your inability to eat. So when you thought it healed itself, it actually worsened and got worse to the point where now it's restricting your ability to function. And that's a really good thing that happens all the time when you're talking to these patients. And that is a really important thing is, did it used to lock? That question is a big, big answer for you. And then the other thing we talked about is the history of trauma. And asking the patient about headaches, neck pains, face pain, really important type of a thing as far as where they feel and how they apply and what they talk about as far as pain. These questions are important to ask because you want to also determine that patient's psychology of how they perceive pain. Because when you start getting your clinical evaluation, when you're doing muscle palpations and you're doing the evaluation of structures, the perception of pain is important because you got to know, do they have any kind of sympathetic dystrophy? Do they have any autonomic problems that you got to work about? Or are they have hypersensitivity to pain? Like you barely touch them, they go, ow. Are they maybe a little bit psychotic? Or is the pain making them psychotic? Because if you've dealt with chronic pain for a long time, chronic pain can make you nuts. Truly, it can. So you can sympathize with the patient, say, well, maybe the little bit of the reason why they're a little bit nuts is because they're in pain all the time. And then what they're doing to manage that pain. Because that's important. Asking that question, if they're suffering some kind of a pain value, what are you doing for the pain? How are you managing this yourself? How are you managing your headaches? How often do you get your headaches? When do you get your headaches? When you get your headaches, what do you do for them to relieve them? A very important process questions. Some patients will tell me, they say, oh no, I get this cluster headache that I get every single morning when I wake up. It's different than my migraine that I get once a month. So it's important finding out what their perception of all their whole pain values are going to be. Most of these patients that are suffering from this are also suffering from some type of a head and neck oriented pain issue. So you have to determine how normal are they or how abnormal they are with the process of their structures that are going on. And if it's abnormal, how abnormal they are. Because most patients don't realize they have some kind of a condition going on or a TM issue going on until you start analyzing them, putting your hands on, asking the right questions, because they've always assumed that that's normal for them. That's normal that their jaw pops and clicks. That's normal when they bring their teeth together, they crunch and slide across the table where they're trying to eat and chew and function. So asking the right question, asking their long-term and short-term goals, and your early diagnosis and education is key to transition these patients, to get them where you can get on an equal basis of what's healthy, what's not healthy, how do we establish your goals. She came in to me from Idaho, and her biggest thing that she did not like was her space between her front two teeth that would open and close daily, and she just had those put on a month ago. They were veneers put on, and they were horrible. She didn't like how they didn't match at all. And I said, yeah, When were those put on? She goes, a month ago. And she goes, and tell me more. What happened? She goes, well, this is the third set that they did, and this is the closest they got. And I say, and so what's your chief concern? I don't like these, and I don't like my space between my teeth. What can you do to fix it? Okay. Do I just tell her I can put 4 pieces of glass across your front teeth and call it quits? Can I bond the space, take those things off? No, I'm going to say, let's look at the big picture. Tell me more about the space on your front teeth. Yeah, it opens and closes. Some days it's open, some days it's closed. What does that usually mean? It means a bite problem. They have some kind of hit and slide. If they have some kind of hit and slide, also what happens to the joint? Do they have any kind of instability in the jaw joint that you have to look at? So you got to look at the big picture before you say, let's look at this little cosmetic concern. Because she had a joint problem, she had a bite problem, she did not have an airway problem, which was amazing. I thought she did, but she didn't. And she had a cosmetic dilemma that she didn't like. So you got to ask the right questions as far as what's going on with the patient and how they perceive what's going on with it. After a long journey that she had of going through splint therapy, going through ortho to help with the minimal type treatment, because she didn't want a lot of treatment. She goes, I just want minimal type treatment, on whatever that means for patients. You kind of ask that question. They go, well, I want minimal dentistry. I don't want a lot done. Well, tell me what you think minimal is. Because minimal to them might be, I'll keep all my teeth, but I don't want to lose them. And I have free range to do everything else you want. Minimal might be, I don't want you to grind on any teeth at all. You know, you got to ask what their concept of minimal is. But she didn't want to do a lot of dentistry, but she wanted this taken care of. And once we talked to her about her jaw joint, her muscles, and the arch form, she goes, well, let's fix the jaw then, and let's go ahead and we did ortho to level her plane back out. And then once we got her plane leveled back out, we were able to not do anything to her front teeth and just redo the 2 veneers on her laterals and close her space and keep it closed. So we were able to do minimal dentistry and just do 2 units, but we had to do joint therapy first, and then we had to do corrective bite therapy and get it so she didn't hit and slide anymore, opening that space back up. So we can still get her concept of minimal dentistry, but we have to get our diagnosis right and what the conditions are that are making her diagnosis and her condition wrong or worsened for her. So when they have abnormality, and this is a study done by Steve Almos, that most patients don't know what's going on with them itself, that 75% of the population has at least one sign or symptom of a TM dysfunction. That's a lot. 3/4 of the patients walking around, coming through your door, have some type of a TM dysfunction. Isn't that crazy? So when you start talking about building a TM practice, a TM-oriented practice, it's easy to build it from within your practice that you have right now. Because 3/4 of the patients have it. 34% of the population base know they have something going on. And 41% of the patients coming in through your door have some condition. They have no idea that that condition is TM related that you can take care of. It could be joint problem. It could be muscle problems. It could be the fact that they have something waiting to go on. So you can build a TM practice within your practice very easily by being cognate, diagnosing and doing biometrics and going through your analysis on all your patients coming through your door. And you can really change that patient's life. So how do we handle this problem with the 41%? It's easy. We screen every patient that comes through our door, as far as a new patient, a referral patient, a second opinion patient, to find out what is the primary stability of the joint doing and the muscles doing for that particular patient. What's going on with their whole inside compartment with their teeth, their gums. They do appreciate a very detailed evaluation. And I hear this all the time. The patient goes and they go, I can't believe I've never had anybody look at all that stuff inside my mouth before. I said, well, great. We value making sure that we can cover all your bases. We like to look at all your structures. We like to look at everything that's going on inside your mouth, your neck, everything that's going on with you that could affect you long term, so we can address it, take care of it, and get to you where you want to be optimally for your health. And that's important because they like that whole detail. And you got to ask a lot of leading questions to establish a great comprehensive model of care. And patients do value it. Now there's some patients that will weed right out off the initial phone call because they don't get that question right. They go, what are you after? What are your goals to treatment? And they may not fit your practice philosophy. Because there's some patients that don't want comprehensive care. You have to realize you don't have to treat all the patients that come in to see you. You've got to treat the patients that want your value of care, your expertise, your ability to change their life. Because not everybody follows that same dream. Probably crazy. You've never heard say, you don't have to treat everybody. You don't. Treat the ones that are going to get value from it. Treat the ones that you want to treat. Because when you get them healthy, you get them satisfied, they're going to send more people just like them. You don't have to say everybody. You can say no. I don't want to be able to do this for you. I'm not going to be able to do this for you. Because some of those instances are the best decision that you and the patient makes. Because some of those are definitely a hassle to deal with. Okay? Those are my pups. They love to go out and roam. So yeah, I'm from Arizona, right? I'm in the desert. Arizona is a unique state where we have big climatic changes of zones, where within 2 hours I can go from like 1,000 feet of low desert, go through high desert to high value trees. This is 7,300 feet elevation. So big pine trees, snow. Yes, we get snow in Arizona. And my dogs love to go out and roam and have a good time. So it's a lot of fun. They really value to be able to get out of the city and enjoy being dogs and running around. So once we get our biometric data, we have to assess the clinical evaluation and see what's going on with the patient clinically. We still got to put our hands on the patient. You know, I do a lot with biometrics, but I still have to correlate my clinical evaluations with my biometric evaluations. I have to correlate my digital, my radiographic information with my biometrics and my clinical conditions. I can't just look at one only. I got to look at the whole package of everything to get a proper, better working diagnosis for this patient. So I got to correlate it. I need to look at their range of motion, making sure that they're opening in a normal manner. I got to make sure that they go into lateral motions in a normal manner. If they're opening and closing, do they have any kind of deviation, deflection issue going on? If they're opening and closing, do they have some kind of restriction on opening? Can they not open to what normal is because of either a disc impingement or a locked disc, or is it a muscle entrapment issue or a soft end feel? And I'll show you how to do that test. But this is important to find out. Is it spastic muscle or is it joint or both, to be able to determine what's going to be going on with that. I want to make sure that when I do feel the popping and clicking, that I can document where those positions are when the patient's opening and closing. Now, we do this two ways in the office. We do this analog, and we use a ruler, a terabyte type ruler, and we also do it with our jaw tracking as well, so we can get both values, because sometimes patients will try to cheat. You know, when you put the jaw tracker on them, they won't open extensively. They're like, they won't go all that way. But you got to check it both ways. And we need to detect if they have any kind of airway breathing problems or clinical signs of airway type issues. And we need to take and translate our imaging from our x-rays, our MRIs, our CBCTs to what we see on our biometrics to get an assimilated diagnosis. There's a lot of information that we have to gather as far as when we're looking through our pain patients, our comprehensive care patients. One of the programs that we use is Dental Writer from Nearman. And they've been a great asset for looking at cross-coding, medical billing, for getting all your data in the right place and working with your forms, because we do like the way the program works and we like the way we can customize it for our needs in our office for what we're doing. So they're a great company to work with, and they have really wonderful forms. But you got to be able to put your information in some place where you can get to it, right? And the cool thing about that program is once you put all your stuff in your computer, as far as all your clinical evaluations, all the stuff that you're seeing with your biometrics, all the stuff that you're seeing with all the stuff that you're doing, then it's easy to take that and it populates it into reports for you, so you don't have to do a lot of extra writing, a lot of extra work. So, and that's one thing I don't want to do, is a lot of extra work. We do enough. So if you can have all your stuff that's readily accessible and you can make it so it's easy in a template, it makes it a lot better. We need to understand the aspects of pain for this particular patient. So when they come in and we're doing our evaluations, establishing what those pain values are, the intensity of the pain, the position of the pain, the onset, the duration, and the relief and the perception of how they feel that pain and what they do to relieve it. So this is important. I showed the patient this because I overlaid her photo with her CBCT and scaled them together. And I showed her this, and I said, oh, I got to show you this picture of you, and brought it up on the screen, and she goes, oh my gosh, I love it. Can you give that to me? It's still to this day, it's hanging up on her refrigerator at her home, and she loves it because it shows a lot. You know, it shows a lot to me, and it shows a lot to her of where she was. She's just getting ready to finish her treatment finally. We finally got her through all her joint, all her rehabilitation, all her regeneration, and she just finished ortho, and we're getting ready to rebuild her wear. And so it's going to be a major transformation for her that, you know, it takes time. She's been in the process for 2 years getting healthy again, and she feels better, and she feels the difference, but she looks back at this every single day of, yeah, that reminds me of how bad I was. And, you know, if you can change somebody's life where they look at that and go, I feel so much better now than I did back then, you know, it makes you feel good. But it's really cool to show patients, because just this image alone of just showing them the 3D of their skull without skin on, they go, that's amazing, because the technology really does impress them quite a bit. So it's really cool having that availability. But you got to also determine what's going on with the head, neck, and back, and what's giving them the headaches. Talk a lot about headaches. Now, one of the things about head, neck, and back, the reason why we talk about that so much, because there's a lot of correlation between forward head posture issues and cervical dysplasia issues. So we got to make sure that we can treat them a certain way. Now, I'm not doing any kind of functional type of chiropractic or physical manipulation or anything like that in my practice. I need to know where I got to send these patients for. I got to find out. I can identify that they have some kind of a cervical problem, but I got to get them somewhere that they can also get worked on to work in correlation when we're starting to get them healthy. And it's important with that. It's the same thing when you're looking at their nose and their sinuses and their ability to breathe through their nose. That if you see something that's restrictive and you determine that they have an upper airway resistance syndrome and they have a nasal type of a system, then getting them to the right ENT, getting them to the ability that you can refer to the right places. I can't do all this stuff without my referral. I have to be able to refer them to the right place. And I have to be able to have them to be on board with my referrals of, if we're going to get you all the way healthy, you're going to have to follow this, this, and this to get us there. And it's not just dentistry, it's other physical medicine that we have to work with you to get you along this journey, because it's not just one thing that's broken down. It's not just your jaw joint. You got a jaw joint, you got a neck, you got an airway issue, and we got to work with that with all these other specialists to get you to get healthy all the way. So it's important that they get on board early, because before I started doing that, I would get great success. Now I have really great success, because you get the patient on board and get them where they need to get to for the physical medicine to get them to heal up the right way. And then documenting on where all that particular structure and pain goes. And that forward head posture type position. What is their airway getting restricted on? How is their angle of their mandible? Is it compromised? Do they have forward head posture? And then how does that neck jaw type issue relate to the back of the neck? Do they have any kind of ascending or descending type postural type of influences information? One of the big things about this is when they do have this forward head posture type of situation, and we start getting them into corrected position, get their orthotics in and getting them work where you can straighten them back out, and they work on their neck, I'm going to tell them that you may start experiencing other areas of pain down your neck and your back. Because once we start getting you out of this accommodated pathological position that you've been in for so long, then you're going to also see other structures that you haven't worked the right way for a lot of years. So we got to make sure that when we start going through this treatment that you follow through with the other postural issues to get you and keep you getting healthy. Because if not, we're going to have some other structure things that we're never going to get you all the way there until we can assess these other issues, because you may start feeling other areas. It's like peeling an onion, talking to the patient. Once I peel one layer away, your immediate pain, we may expose something else that's secondary that's also causing you pain. So you have to realize that this is a work that we're going to be removing your primaries, your secondaries, your tertiary problems as we go along. Other things may develop that are hidden because you have so much pain in one other area. So it's important to talk to the patient about what to expect if they start going through treatment. And this is that same lady. She was pretty jumbled up. She had a lot of wear. Now you can see why we have to rebuild some areas because of extensive wear. She doesn't look like this anymore, thank goodness. But we have to look at their history and what does the history help us in our findings. We need to still look at the muscles, the joints, the top of the teeth. Because that patient's goal may be, yeah, I want to be out of pain. And I want my smile to look better, and I want to do orthodontics, but I don't want to put anything back on my teeth. I don't want veneers. I don't want crowns. And you got to be able to talk to the patient about because of the amount of wear that you have pathologically, that you've worn down because of where you are now, I'm going to have to do something. Even if we move teeth orthodontically, I'm going to have to put something back on those teeth to get your structure back. Because if you've worn into dentin, that's a bad scenario. We can't deal with that. We've got to put something back on it to preserve it so you don't continue to wear it abnormally fast. We need to look at what kind of trauma is going on, what type, what history of the trauma is going on. Ask the leading questions. Was it because of extractions? Was it trauma due to ortho? Ooh, the orthodontists don't like Thomas, right? The orthodontists don't like to hear that. Is it something that went wrong in ortho that positioned them wrong, that the orthodontist didn't pay attention to because they were too interested in getting Johnny's smile right to make it so their teeth are straight? But they really didn't care where the jaw was when they started going through treatment.
You don't care. Flying under the radar.
Flying under the radar. Well, you see, you're not the same kind of orthodontist now because you're here. But there's a lot of other ones that are just want Johnny's teeth straight and get him out the door. Huh? Yeah, really, for sure. Yeah, a lion orthodontist. I like that. That's cool. There is a different way. So, but there's a lot. Is it because of this and this in combination? You look at her. She had both things going on. She got amputations. They took her premolars out. And they also did early ortho, and she collapsed. And then she had vertical collapse, airway collapse, and she had tooth wear because of it, and her jaw got slammed back. Well, because of the position she was put in, she was destined to failure. She didn't have any physical, accident trauma. She had iatrogenic trauma and then collapse, which is worse because we caused it. Not us, but we have to fix it. But that's something you have to look at, is what can we do to get you from point A to point B now? And what are the ramifications we need to do to get you there? Okay? Do they have wear? Do they have erosion? Do they have other issues that are going on that are helping them to break down their dentition, their enamel going into dentin? Is their range of motion normal or abnormal? And what happens when they bring their teeth together? Now, I'm a big proponent for this. I like to show my patients this clinically to see what goes on, because they don't realize sometimes that their bite is so bad until you show them. And when you show them that they have an enormous hit and slide from a posterior tooth rocking forward, and then their jaw fits together pathologically, and then you show them where that corrected functional position is supposed to be without the slide, they go, oh, wow. And then you have them do that, and you push on that masseter where they're complaining about where their pain is, and you push on that as they slide, they go, oh, yeah. Oh, where that bulged right there is where that hurt, right when that tooth hit and I clenched. Yeah. So you show them the ramifications, what's going on with the bad bite, and show it to them. It's awesome where they go, oh my gosh, so this is the whole problem all along. Well, it goes a little further than that. Because your jaw is collapsing because of the bite issue, we got to fix the jaw first. We can't just fix the bite. So that's where our biometrics is hugely important to determine, is this a primary occlusion issue, or is this a joint occlusion issue that we need to fix? Because if we try to fix just teeth, sometimes we can't fix just teeth and the joint won't follow suit because it's in too much of a pathologic position. So it's important to understand where you can go with your treatment to get them healthy or not healthy. Do your arch evaluation. Are things where they're supposed to be, or is it too abstract where they have too much curve issues, too much tooth missing issues? What do you need to do to get their arch back to normal, and what kind of noise their joint makes and what noise it makes at different positions? And looking at their soft tissue. Where is their soft tissue? What's going on with the palate? What's going on with the tongue? And can they breathe? Can they function? Do they have airway flow? Because they got to still be able to breathe. And what do we need to do to fix that? So when we start going through and we're looking at our range of motion, as I said, we do it both ways in the practice. We'll do it analog, and then we'll also do it with our JT. But I want to see what happens with the patient when we have the patient physically moving in a motion to get it where we can see where they're going to go. And these are the rulers that we're using right now in our practice. And this is my lab. This is my practice. The biting edge of my lab is called the biting edge lab. As I said, if you want some cards, I have them upon the table. Our maximum opening, we want to make sure that the patient's going to open 40 or more in a normal type of a classification system to make sure that they can open normal. And a lot of patients, they just get lazy. They go, okay, they open. I say, okay, is that as far as you can open? Can you open farther? You know, like Ray was talking about this morning, put your hands up. Okay, now put them really far up. Well, that's a lot of times what patients do. So when you're running your JT analysis and the patient opens, they might just be going to where that normal, comfortable opening is, and that may be a pathological opening when you look at it and you analyze it. So you want to make sure that they're opening as far as they can with stretch. Okay? That's an important part because you can get a misleading diagnosis if you don't do that. I want to evaluate their right and left lateral. Same scenario. Go slide to the left as far as you can. Okay, can you go more? And you have to also determine, is this a sliding problem or is this a trapped occlusion problem for the patient, or is it a joint problem? Because a lot of times the patient will put their teeth together and you go to the left. I can't. Why? My teeth are hitting. Okay, go ahead and just let your jaw relax. Swallow for me. They swallow. Now, lick your lips. Let your teeth come apart slightly. Now move your jaw as far as you can to the left, because it takes that entrapment issue away. So it's not a muscle issue, it's a I'm not listening to you issue, and I'm holding my teeth together issue. So understanding that verbiage for the patient so they know that they can move their jaw in a normal motion to see is it restrictive or not restrictive. Now, one of the big things we have to look at our right and left lateral motions is when they go right and left, do they have equal opening right and left at 6.8 millimeters or more? And that's where we need to look at. Can they do that? If they can't, if they go 13 one direction and 7 one direction, is that normal? No, they got an abnormality. You got to figure out what the abnormality is. If they can go 4 one direction and 6.8 the other direction, they have an abnormality. So they should have very equal right and left lateral motions if they have a normality that's going on. If they have an abnormality that's going on, you're going to see some restriction in one different direction or not. You also want to look at their protrusive movement. When they come, they put their teeth out, like do that little bulldog thing. When they slide their lower jaw out, does it go straight or does it have some kind of a deviation, deflection that goes on with it? Yes, because that's going to also tell you that they have a unilateral, bilateral joint problem that's going on. And when they open and close in their normal opening cycle, do they have a deviation and or a deflection? So yes, they can have both. You can't just have one or the other. You can have both, because you have two joints that you're working with. You can have one joint that's locked and you have one joint that's coming on and off. So you can have a deviation and a deflection. The patient opens in their cycle. So you need to look at both and see if they have it, and then document where they have it and document where you see it and where does it end. Because if they have some kind of a deflection, most probably it's some kind of a disc that's off and they're going to deflect towards that affected side. So it's important to document where it is. Okay? And then so you go through your clinical motions of where they're going to be. And this is our hard and soft end field test, looking to see, is it a muscle impingement issue or is a disc trap issue? And you have the patient open as wide as they can, and you use your finger and your thumb like a jack screw, and you put it between their teeth, and you tell them open, 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 and you stretch them. Look at the value of where they are opening. If you stretch them past the 40 millimeters, it's most probably a muscle issue, a muscle spasm, muscle tightness, a muscle hyperactivity issue. If you go and it's like hitting a brick wall, it's a joint issue. If you have both, if they stretch, but they don't stretch past 40, and then you hit the brick wall, then it's most probably a both. It's a muscle issue and a joint issue. Because a lot of times they get that joint, that disc lock issue, they go through the muscle spasm for protection, and you can stretch them a little bit, but you're still in the brick wall, you can't get past the disc. So that's one thing that's important to establish. Is it a soft and hard end feel? And that's what the test is called. It's a very important part of any of your exams if you have a patient that has restricted motion. Okay. Now we'll take our pain function findings results, and I do need to put my fingers on the patient. I do need to palpate. I do need to see what's going on when they open and close. One of those things that when you're starting to palpate, I'll get on this side so it's easier for you guys to see. And as I said, I love to wander. I get bored if I stand in one place. So we need to look at the lateral pole and the posterior space of the condyle. So a lot of times we're putting our fingers on the patient, and I really love doing this on these patients that have this quiet partial disc displacement. And you've already seen it because you've seen your initial diagnosis on your JVA. You say, oh, okay, they have a 3A or they have a 3B type situation. They go open and they close, open and they close. And you put your fingers on them, and they've already said, I don't hear my jaw, it doesn't pop and click. And you put your fingers on the lateral pole, and you hold the lateral pole, and they open, and it goes pop, 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 pop. Like, wow, Miss Jones, how long has that done that? It didn't do it until you pushed on it. So they're kind of like blaming you, right? And you say, oh, Miss Jones, now you do that. You put your fingers and you push right over that bulge of your jaw joint. Now you open and close. and they have the same thing. They go, oh wow, I didn't know it did that. Okay? Now, those are those patients that are extremely important that you talk about proactive care. Because that's that quiet partial disc that's displacing that could go worse if they have any kind of other microtraumas, if they have any kind of other physical traumas, or if it's just something that's just going to make it so they get worsened. So those are really important that you start talking to Ms. Jones about proactive. It's like, now Ms. Jones, what happens here is your jaw is partially dislocating itself. When I put pressure on the outside, it's tightening the complex of where the assembly, where the ligaments are attached. And when you're opening and closing now, you can feel that popping back over the top of that jaw joint. So it is dislocating itself as you open and close. Now, one of the things that we need to do is we can test you to see if we can put you in any kind of an appliance, if this is going to help make it so it doesn't continue to get worsened. Because a lot of those early partial disc displacements are, you know, like late in closing, early in translation. So those are sometimes very easy to treat, or at least easier to treat. And one of the early things that we use on those particular patients is we'll use either a stick and just have them positioned and open and close without their teeth coming together. It's also one way to find out, is this an occlusion issue and a joint issue that goes together? Or we can put them into a quick splint as well and test it with a quick splint and have them open and close and put the pressure back over it and see, are they still popping and clicking? And I'll show you how we do that when we look at our JVA analysis on getting our documentation of that. Not just the patient's palpation of it, but how can we put this on our diagnostics to see what kind of value do we really get from early proactive treatment. So it's important to be able to get the patient's education and trust that this is going on because you have a system disorder. You have a dislocation that's going on, you may have a bite problem that's going on, you have a hit and slide issue that's going on. We need to know what's going on with that. And then the other big thing about this is, do they have pain? You know, do they have pain when they do that? When you're pushing on them, do they have pain when they do that? Do they have any kind of capsulitis when you slip your fingers back in the posterior capsule and they open and close? Does it hurt? And which side does it hurt on? Because that's also a big motivator of, if it hurts, where does it hurt? One of the things that we need to do too is, before we start like pushing the patient and getting values of pain and doing our muscle palpations, is we got to quantify baseline first. So you need to ask Miss Jones or Mr. Jones or anybody you're touching. It's like, you know, I'm gonna push on some structures here to see, are they normal or abnormal, or if they're causing any kind of pain. So you got to ask for permission. And when you do that, you also need to quantify it. So when you go to Miss Jones and you say, Miss Jones, can I push on your arm? And Miss Jones says, yeah, go ahead. And they get baffled. They go, yeah, go ahead. I say, okay, Miss Jones, I'm going to push like this hard. This is like 3 to 5 pounds of pressure. Does that cause any pain in your arm? And they say yes or no. Okay, if they say yes, that does, go somewhere else. Find a spot to get a relative value. Because what you need to do is get a baseline of, if I barely push, if I just push 3 to 5 pounds of pressure on this muscle, is it going to cause you pain? And if it does, we need to talk about what can we do to eliminate that pain. But you got to ask permission first. You got to get a baseline of what 0 is. Because if you push on a guy and you say, okay, Mr. Jones, I'm going to push on these areas, does this give you any pain? And they go, no. Well, you know, there's like, yeah, they're too macho. They're going to say, no, it doesn't give me pain. I'm macho, man. I don't have pain. But if you get a baseline first, it's like, does this cause you pain? Yeah, that does. Well, you know, what happens is, because this is a muscle that you're using all the time, that you're opening, you're closing, you're grinding, you're chewing, you're doing all this work with these muscles. It's like if you go to the gym and you do bicep curls and you're working out really hard that one day, the next day, what happens? They go, yeah, my arm hurts. Well, that's the same thing I'm looking at, is, are you overworking the muscles that you work with to be able to eat, chew, and function? And if you're overworking these muscles, we got to figure out a way that we can keep you from getting pain by overworking these muscles. And that could be as simple as going to a proactive, very simple night appliance. Or it could be the fact that because you have so much stuff that's breaking down in your jaw joint, that we got to go to a day type, we have to go to a full activation appliance to get it where we can get your structures back in shape so they're not hurting. Because if that hurts now, it may start hurting worse, where you feel that perception of pain all the time. So establish relevance and establish what those values are now before you start pushing on them. Because Macho Man may say, no, nothing hurts, when you know they're wincing in pain because they don't want to admit it. The basic palpations that we're going to be doing on these initial patients are temporalis, anterior, middle, and posterior, our temporal tendon insertion in the coronoid process, and our masseter, our superficial body. I also, on all those, I palpate on the stylomandibular as well. And these are our basic ones that we're going to be going through. When we're doing our full TM analysis, we're going to do the whole work of muscles. But just for our basic evaluation, getting these primary opens and closers to make sure if they're having any kind of wear. Now, I like to palpate intraoral muscles first before I go to extraoral muscles, because I put my gloves on and I like to do that first. The reason is when you go through and you say, oh, Mr. Jones, and you go through and you know, who knows what kind of hair gel or cologne they put on that day, and you go and palpate everything around their head, and then you go inside their mouth, they go, it's like, yo, sorry, that's you. So I like to go have fresh gloves in and go in oral first, and then I can go extra oral on that. They don't care if their spit gets in their hair, but they care about if that hair gel gets in their mouth. And it's also for ladies that wear makeup and perfume. It's just like, it's kind of gross. I don't want that crap in my mouth, and they don't either. So it's do the intraoral ones first, and then come do the extraorals, and they'll be thankful for that with the taste. Once we get through the palpations, we're going to determine if there's any kind of pain structures. And we make it easy on our palpations. I make it as 0 is nothing, 1 is slight, 2 is moderate, 3 severe. Really simple. We don't use the VAS scale when we're doing our baselines because it's too hard. If you go from 0 to 10, the 10 worst pain possible, the patient's like, I don't know, that's a 4, a 5, a 7. It's too many values to deal with. All I want to know is, does it have any pain? Is it mild, moderate, severe? That's it. That's all I want to know for my baseline. It makes it much more streamlined. Okay? Once you get into active treatment, then you can go into really true muscle palpations of the quantifying it, but we need to know our baseline first. When we're going through our baseline pain function finding oral exam, we need to find out, do they have wear, pathway wear, attritional wear, erosional wear? What's going on with the enamel of their teeth? How does the structures look? Do they have wear in the dentin? If they have wear in the dentin, then you got to talk about what do we need to do long term to preserve the teeth that you have, or you're going to continue to erode and wear them away to a point where you may not have teeth anymore. Do they have any kind of parafunctional type lesions, abfractions, non-cervical carious lesions, and some people would say toothbrush abrasion. Now, how did Susie the hygienist get away with all these years of telling Mrs. Jones, oh honey, that big old knot you have at your gum line's toothbrush abrasion. You just brush your teeth too hard right there. And they automatically become the expert, right? How did they get that way? The patients value your hygienist. So when you start talking about dysfunction, you start talking about wear, educate your hygienist about what's true and what's not true. What happens in these scenarios? What's breaking down? What's causing the breakdown? And we see so much. You see non-cervical carious lesions every day in your practice, right? I know I do. One of the things to do is educate the patient because it's a force issue. Force breaks it down first. Then the erosion, the acids, the toothbrush, the foods, the acid, all that stuff gets to it and helps it erode more. So one thing I do to explain that to my patients is a really simple analogy. And I like analogies. I like to be able to talk to my patients certain ways so they understand it. So Miss Jones, that lesion, that little cleft, that notch you have at the gum line of that tooth is because of force going the wrong direction on your tooth. You have a bite problem that's there. They go, but she said it was like I brushed my teeth too hard. Well, what happens first is that tooth is anchored in bone. So you have a root that goes down. And that bone surrounds the root of the tooth, and then the crown of the tooth comes up out of the gum line. Now that tooth is designed, it has like little shock absorbers under it. It's designed so as you bite down and chew, it compresses and comes in and out with those little shock absorbers. Now, if you bend that tooth side to side, something else happens. It's like if you take a piece of metal and you put a piece of metal and clamp it onto a vise. Well, all that part going below the vise is that root of the tooth going down. And that part above it is the crown of your tooth where you chew on. If I take that and I hit it on top, it's not going to do much. It may just slide down. That's what the shock absorber do with the teeth. But if I start bending that piece of metal side to side, what's going to happen over time? They initially say, it's going to break. Well, you're on the way to that right now. That's what that crease is at the gum line. You're creasing that. Because as soon as you start bending that metal, you get that crease right at that joint, right at that interface of where the vise is holding it together. That's where the bone in your gum is on the tooth. Now you see on your tooth, can you put the picture up on the screen? You see your gum is kind of pushed away and it's starting to go away, going down. Well, what's happened with you bending your tooth side to side for so long, the bone has regressed away. The bone is breaking away right there, and the gum follows the bone. That's why that tooth looks long. That's why you're getting long in the tooth there. It's not because you're brushing it away right now. The etiology of where it came from is a bite problem, because you're bending, 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 and eventually it will break. But I want to fix this before it breaks. It's not just putting filling in it, but it's fixing the structure. It's fixing how it comes together. It's getting it so you can fix their whole system, not just one part at a time. And when they hear that, they go, oh, that makes sense. And they still go back to, well, how come Susie told me that? I can't answer for Susie, but all I can tell you is this is where you are now, and we're going to be able to fix this as long as we can continue with our plan and get you healthy. But the last thing I want to see you do is break your tooth off. Oh, okay. So explaining things to patients are really important, especially on things like that. Talk to them about edges of teeth and uneven wear, of how the teeth fit coming together. Because if they have a large hit inside, if their teeth are starting to interdigitate weird, you need to figure out why. If they have pattern wear, figure out where the pattern wear is it. If they have a tooth on an anterior tooth and you see scalloping, you see wear, you see a chip, ask them, how did you get that chip on that tooth? I don't know. It just showed up. Okay, that makes me worry. Or if it's, no, I bit into a fork and I broke the edge off. I'm such a klutz. Okay, great. I'd rather have a forking accident like that than if they have an unexplained wear accident that's going on. So it's really important to find out how things broke, how these teeth fit together. And we want to find out, do they have any kind of closing interferences? Do they have a working or non-working interferences when they go into lateral function, or any kind of protrusive motion? Now, once we go through and look at all that, I like to do functional tests on patients when I put my hands on them before I start going through clinical evaluation. So I want to put them in to see what do we need to do if we put something between the teeth via an aqualizer, a stick, a quick splint, or a cotton roll. If I put something between these teeth and get the occlusion out of the way, does it help any immediate ramifications that are going on with the muscles of the jaw joint? Okay, I like that functional test because that's going to help me go through when I'm going through my biometrics to see what can we do to work with this patient to get their structures better. Okay, so why I like to run biometrics is I got to understand my baseline. I got to know what happens now. Where are they now? What do we have to work with? And I need to know what I'm dealing with before I jump into any kind of treatment. I got to know what's happening with the jaw joint, the muscles, the system. If they're normal or abnormal, how abnormal are they? What kind of pathology is there? And to what extent of treatment do we need to go through to get back to their wants, their goals, their desires, to get them healthy? And I use my baseline, my biometrics to also to see, am I improving the condition? I measure over time. I want to make sure I'm going to develop a model for complete success so I can allow this patient to get healthy and get them as healthy as fast as I can. Or if they have too much pathology, what the compromise is going to be and what we can accomplish or what we can't. Improved diagnostics leads to improved treatment. It also leads to more comprehensive treatment for the patient. And that's what we're after, total health. We want to make sure we get them as healthy as we can. So let's look at the jaw joint. So as we know, the jaw joint is our first determinative occlusion. Well, our jaw joint's also our last determinative occlusion. It works in two aspects. It gets them there, and then once they clinch and put everything together, then it's our final resting point where all the stress goes to. So it's our first and last determinative occlusion. So we need to make sure that this system is working right before we do anything else. Because if this moves, if this slips, because we lose our lateral or posterior support of our ligament space of our disc, if this slips forward and anterior or medial, then this is going to change the position of this joint. If they have swelling or inflammation back in this disc space and it's going to drop back down, it's going to change the vertical position of this joint. If they've lost the disc all the way, it's going to change the vertical dimension of this joint. So anything that happens up here is also going to translate and happen to the teeth. Okay? That's why we have to look at both structures. That's why I have to look at, is my joint healthy or not healthy or inflamed? And how my teeth come together. So I need to look at my biometrics with my JVA, and I have to look at my T-scan analysis with my teeth. What's correlating? Do they correlate together? Is it the bite, or is it the joint, or is it both? Because if it's both, I got to settle the joint first before I settle the teeth first. So it's important to know what's going on with the joint here itself. Because as this changes, it's going to change my occlusion. Positional changes in the jaw joint we need to get under control first before we activate permanent changes of teeth. Because it's going to be important so we can be as conservative as we can for the disc relationships that we want. So we want to have a normal disc relationship, a normal ligamentous, and a normal muscle relationship. We need to have this biconcave disc firmly adapted around the head of the condyle. Or in a partial disc displacement, it's going to be moving off the lateral pole, moving anterior and forward. Depending on how much ligament damage we have, depends on how much partially displacement we have or movement of that disc assembly going around the disc itself. And this gives you a better view of what that partial disc displacement looks like when it's off of its condyle head. Now this is important. When we're looking at our joint vibration analysis, this is what we're analyzing. We're analyzing this disc itself coming off the pole. Now when we see a partial disc displacement, we're only coming off one pole of the condyle. So that's where we see a one blip. And I'll show you what that looks like on the blip. When it comes off both, we're seeing it come off both sides, so we get the double blip. So when we look at it, it's easy to determine what a partial disc displacement is with a complete disc displacement because of the amount of disc that's coming off one pole or two poles of the condyle. Okay? So this is what I love about joint vibration analysis. I know a lot of people love Doppler. Doppler, all it is an acoustic sound where it just gets the patient on board that they have something going on. It's a good education tool, but if you already have joint vibration analysis and you want to educate the patient, play your Doppler setting once you run your trace, because then it gives you a simulated Doppler setting with your JVA, and you get the pop and click and the bleeps and all that stuff that's going on, so you get best of both worlds. You can get an audio representation of it, and you can show them visually and physically as well. So I like that as far as that. But you got to have the right tool for the right job. You got to make sure that you can do the job that you can the best and easiest way possible. Can I get through this tree with a handsaw? Eventually, but man, I'd rather have a big chainsaw to cut that baby down, and that's what my JVA and my JT are. It's my big chainsaw. I want to be able to get the job done the best way I can. And the simple principle of JVA is it's working on friction. You know, how much friction is going on inside that complex? And we'll measure friction. Each friction of different disorders makes a certain waveform and a pattern. And what we're going to do is measure that waveform and pattern to find out what type of destruction we have that's going on. And then we can also utilize, if we do positional testing on the patient, if we put them into a quick splint or we put them into a corrected bite position, are we reducing friction immediately? And if we're reducing friction immediately, how much are we going to change so that patient can adapt back to a healthier position? And that's what we're going to be doing on here later is measuring what we're seeing as far as with our baseline joint condition. So we need to take control. We got to understand our baseline, test our treatment positions. And I'll show you different ways to test to find out if we reduce the friction in the jaw joint, can we get the system to start working better? We need to identify early on of the best direction to promote the healing and treat and track for success, and we'll use our biometrics or our functional testing. And I'm going to test my splints and test my bite positions before I make them. Don't you hate it when you take a bite position and you say, oh, this looks really good, and you send it to XYZ lab, they make you some kind of an orthotic, you put it in, and then you get this thing back, and the patient comes back a couple months later and you say, this didn't work, right? I don't like that. I don't like to prescribe that kind of treatment. I like to test this position before I ever deliver a splint to see, am I going to reduce friction so I can treat and track for success and I can get this patient as healthy as I can. I don't like to work it out in plastic to see, can the patient take it or not take it. Let's get them to the right place first, and then let's work from there, because you're going to get a lot better, faster success as you go that direction. And I need to test my joint position prior to treatment. So let's look at what basic things we're going to look at in a basic interpretation. All I want to know is, am I normal or abnormal, and then what stage of abnormality the patient is, and then can I treat or transform them to any kind of degree of normalcy for that particular condition that's there. Because if they have a complete disc displacement that's totally gone, I may not be getting that tissue back. It may not be, quote, recapturable or readaptable, but I got to make sure that we can treat and transform them in the best possible position that we can. And what I'm looking for on my JVA exam is I'm looking for normal. And then if I see normal, Then I got to go do one extra step and verify my range of motions. Is this normal, or this is a complete adaptive disc displacement that looks like normal? I got to make sure they have everything that's normal. So if I see normal, I have to get really critical, because is it really normal, or is it an adaptive disc that's displaced? So it's really important to know that. And I'm looking for these two particular are huge as far as proactive care. Disc movement, ligament laxity, and partial disc displacements. Because when I see that, I really have to get on my education bubble to talk about proactive treatment to the patient. Let's do something before it gets worse. What can we do to solve your needs and get your desires back, to get you back healthy again? Complete disc displacements without reduction, degenerations. We do look at inflammation in our JVA. And yes, I look initially at my occlusal balance when I'm looking at my JVA to see, are the teeth coming together with the right force? Are they coming together on the right sides together? Or do they have imbalance the way their occlusion comes together? If I see imbalance on my initial trace with my JVA, I'm getting my T-scan out for sure, because now I got to correlate. Do I have a bite problem and a joint problem, or is it just a bite problem or just a joint problem? So I got to make sure that I can have all the pieces of the puzzle before I start putting my puzzle together with the corrected treatment that we prescribe. Our diagnostic modalities. This is what the latest value that I got from BioRESEARCH was as far as the effectiveness and efficiency when we're looking at our diagnosis with biometrics. And this becomes into a big play, where if you're going to be looking at analysis of different ways, stethoscopes, where you're going to be looking at 17 to 40% predictability of the right condition that's there, Doppler 40% or 42% as far as looking at the efficiency of it for diagnosis. I would much rather have this value in through here, both my biometrics, than if I'm looking at any other objective type measurement tool. So this is our JVA Quick. She's going to run our range of motions first before we do any kind of tracing to see, is it working, is it not working? What does the jaw do when they open and they close? They do this even before they put the headset on. They do this before they do JT as well, to see, are they opening, and what is the value that we're going to be looking for when they open? And it's very simple. She's going to put that back over the condylar bulge, the translation that they have when they open and close, and she's going to follow the metronome, open as wide as she can and close, and we want to hear a visible tooth tap. Okay, pretty simple, pretty straightforward. It doesn't take much time to do that, and that would be their JVA Quick. This is what we're looking at in our movie when we're seeing our JVA Quick. We're looking to make sure that we get timing of our tooth coming together somewhere close to our little flat point, our little closure point up at the very top part of the graft, and we're going to be looking to see, what does everything look like? Do we have any kind of blips, any kind of events happening between opening and closing? Okay, we're looking to see, is it normal or abnormal? If my girls see that they have some degree of abnormality in here, they're going to do some follow-up tests for me. Okay? And we'll talk about follow-up tests. Now, once we see our value of our opening and closing, we do everything with our JT on it. They'll do an initial range of motions to make sure they can correlate our range of motions, and then they put the jaw tracker on them. I don't run just JVA Quick very often. I'll only run JVA Quick now is if I'm doing a quick test. I'm doing a quick splint test or a quick bite test, because they've already done it. I already know what I'm looking for, and I'm looking to see what I needed to change as far as treatment-wise or therapy-wise. But we're doing all of our diagnosis. Everything goes on with the jaw tracker, because I want to see corrected motion. I want to see where their true range of motion is, the exact position of where the event's going to be, and I want to find out how much real deviation deflection that patient has as they open and close. Now, I'm astute. I have, I visually can see really, really well. Not far away, but close up. That's why I gotta wear glasses. And it's hard for me when I'm standing right in front of that patient and I say, go ahead and open, close, open, close. Well, our value is 3 millimeters if we have deviation deflection above 3 millimeters, right? How hard is it to see 3 millimeters of a deviation deflection? It's tough, man. Do you have your right diagnosis if you're just doing quick? So we like to see what our values are, analog, but we do all of our objective measuring off of our JT, because then I can get my corrected values. Is it truly above 3 millimeters? Do they have a deviation deflection? I want to know what's really happening so I can streamline my effective eye analysis and my waveform recognition. The other thing that this is also giving me is, how fast can that patient open and close in a normal manner? And do they have restriction? Because that's one thing it's really hard to see, is velocity restriction on an analog method. You can see the little deviation. You can see a deflection, but it's hard to see the value of speed change and how much it changes. Because where this change happens is usually where an event is starting to occur. So that's something that we need to look at as far as where does our velocity change and how does that change for the reflector we're looking at. And it also makes it so we have easier waveform recognition. We can split our waveform out better, especially if this event is happening close to occlusion on the end cycle or early opening. It's much easier to do your analysis to see what's going on with this and how do I need to separate this value back out. And it's very easy then to see what is my occlusal balance. Do I have proper occlusion time right and left, or do I not? And so it's much easier to see those values on with your JT on. So what we're looking at is our range of motion with our JT on it. We're looking to see what kind of an AP, a normal swing or crossover we have as that patient opens and closes. Our frontal view, do they have any kind of deviation, deflection? Now, Bio's made it really easy, made it really doctor stupid simple, where the red font, the green font, the yellow font, this font, the red that makes here is your opening cycle. The opposite color is the closing cycle. So they make it stupidly simple. So it makes it simple so that you can see the same thing here. And then this is the opening cycle, the closing cycle. This is what I love, love, love about our range of motion guide with our JT on it, because I can't see this any other way. Because the patients usually don't consent to me cutting off this top skull of their head for me to see how this jaw does this as they open and close. This pitch, yaw, roll rotation here of the jaw joint. They just won't let you do it. So I can see it with my jaw tracker on it. So this is very valuable to me. And it also tells us, can we see, do they have to alter a lateral direction because of a disc impingement that's there? Do they have a partially displaced disc that's causing them to hit and roll into an anterior direction to get around that disc because of a medial displaced disc or a partially displaced disc? Or is it something that's flat? So it's an important thing for me to see that value here to determine 3As, 3Bs, 4As, 4Bs. In the velocity, as I said, do they have restriction of that opening? Can they open above that 320 to 400 milliseconds? Is it a normal oval opening cycle? Where their crossover is. And the thing about this is we know that we have something going on disc-wise here because we have this crossover here, and then we have something restriction-wise. This is a double crossover that we have that's going on here. This is usually characteristic, a double crossover of a disc displacement with reduction, a 4A type of a scenario. So we need to look at, see what's our range going, what's our AP, or is it a flat AP? Do they have rotation and translation, or they just have rotation and they're not going into translation? Because that's going to help me show that. And this is what the headset all looks together on it, and this is the patient that we're going to be looking at. Ooh, it's hard to see. Where they have a double crossover, they have a deviation with deflection on the end. So deviation with deflection, we're going to be looking at one joint's going to be pop, click, one joint's going to be off when they go to final opening. So they have a 4A type scenario, and then they have a lock disc, 4B type scenario.
Whenever you get to a point, we'll let you guys break first. Whenever you guys, if you get to a good breaking point here in the next.
Okay. Give me a couple minutes, and we'll do it. All right, and then we're looking at this closing, this velocity cycle. This right here also correlates with this here, okay, which correlates where the disc is coming on and off. So it's important to see that value, and it's going to help us delineate where we're looking at on our trace of what's beneficial for the patient. This is Sunny at King Yi, right? Is that? Kim. And they put together a multifactorial clinic at the university where they're doing full JVA analysis with JT in their clinic for all their advanced studies and ortho studies, which is a pretty cool thing. And then from my understanding that Yangshi also just integrated JVA into their clinic as well. So I implore them, it's awesome, because I wish more our US schools would entertain putting this technology into their programs, because it's very beneficial. So we're looking at the layout of what we're looking for. So one of the big things I always get as far as, what do I click? The opening or closing vibration, right? So you got to find out what you're going to click. Is it an opening? You're always going to diagnose to the worst condition that's there, okay? So your diagnosis, you're going to go to the worst thing that you see. And it may be on the opening cycle of where the reduction is, because the reduction is usually louder. as it comes back on. But when I'm looking at therapy, if I have a patient in an appliance or I have them in a corrected bite position, I'm looking at what is my relevance of coming off. How much displacement is going to happen as they close? Because if I can change the friction of the disc coming off, it's going to automatically change the friction of the disc coming on. This is my relevance point. So when I'm looking at diagnosis, I'm saying, hey, my worst condition is this, but as I'm getting them into a bite position, I want to make sure I can change this, and I can change this to get it where I can reduce the off. Because the off is the torque, the off is the pressure that's coming off, allowing that joint to get pushed in the wrong direction as they compress. So that's important, okay? And so we'll look at our vibrations, our numbers, and we'll look at our single events versus our multiple events. And it still amazes me to this day that this complex of a structure that has rotation, translation, that you have ligaments and discs and everything that's supposed to be staying on this slippery slope of this gangliomolar joint, that you can have this vibration at the same point, at the same time, within milliseconds of itself, every single time they open and close. It's still amazing to me. It's just it's a remarkable type of an apparatus. And we want to look at all of our baseline information with our traces of our waveform, our numbers, and looking at how much friction is going on with our hard and soft tissue and how much inflammation is going on with the disc itself that's going on in that situation, of what's going on over 300 and what's going on in our start of our movie. Okay, and these are the basic line forms that we're going to be looking at, that we're going to be looking for. Normal, quantifying if it is normal, if we have an open waveform disc movement. Partial displacement, this is the reason why we just have the up, down, down again, is because we just have it coming off the one lip. Okay, so you're only getting that one pop coming off the lip. When you have it coming off both lips, where you have it in the medial and lateral pole, is where you get the blip blip. Okay, it happens really fast, so you don't hear a blip blip, but you'll see the blip blip on your trace here itself. That's why it's two poles instead of one pole. That's why you get the extra activation. Okay, and then degeneration, it's randomized everywhere. So we'll look at disc movement can happen anywhere, and this is particularly important when we're looking at if it happens just before tooth contact or it happens right at immediate opening. It's really important to look at this because this is the sign of something that could happen. If they get inflamed and they start putting micro pressures and micro trauma to that, it's going to be worse. This is looking at an immediate, right coming into closure, they have this blip, they have this disc movement. The partial disc displacement where it's coming off the one pole, and that's where it pops back off. Here we're coming as it pops right back on, coming into right into opening. This is where jaw tracker is hugely valuable because this is coming right into opening. As soon as they decompress, this is at 1.6 millimeters. Now when I see something like this that's right at closure and right at opening, then I want to find out is this because of an occlusal slide? Is this disc relationship problem because of occlusion? If I take the pressure of the closing artifact away with a really simple bite test, and this goes away, we may be able to treat this patient for parafunction inflammation and correct their bite and not have to go through split therapy to keep that recaptured. So this is where it helps us to quantify by having both technologies of having JVA and having T-scan to see what can we do to quantify, is that just a bite problem causing a disc slippage. Okay? Complete disc displacement, as I said, comes on and off both poles. And it's characteristic. A disc displacement with reduction and a partial disc displacement with reduction look characteristically different because of the multi-waveform that's there. This is the new revised waveform and sheet that we use. The biggest difference between this one and the other ones that were out there is our numbers are expanded to fit more of the conditions that you see. And this also adds for extra as far as partial disc displacement, ligament laxity, and pre-DDRs. This helps to separate out your numbers to make it so your waveforms and your conditions and your numbers match better in your forms. So ask Bio for these. These are the new revised forms that we devised a couple years ago. So this helps with your conditions. If you're still using the waveform template, it just helps you get a better definitive diagnosis. And this, we can take a break right here. This is my condyle in the sky. I love clouds. I love looking at things. So here's my posterior capsule. Here's the anterior compartment, and it comes down. Okay. Can we take a quick break? Can we take like 10 minutes? Cool? Sure. 10 minutes, get some water, get rid of water. Yes. And we'll get going, because I want to try to cover a lot of information.
Could you change the
picture.
A condyle in the sky. So let's look at what I'm looking at also when I start to look at the way teeth come together. I'm looking at my occlusal timing issues. And when I'm looking at my occlusal timing, you know, I'm going to look to see how my teeth come together and what is coming together first and how hard that's coming together when I'm looking at my values. So you can compare each bite analysis with each bite analysis. But what I'm looking at is, I can't tell you what tooth it is, but I can tell you, is it the right or left side? And what's instigating the bite imbalance? So when I see something like this on a trace, I'm going to say, I have occlusal imbalance. I need to get my T-scan out, and I got to see, okay, where's my occlusal imbalance? Because I got to have both sides of the puzzle. What's going on with it and how it's coming together? And so here on that trace, that's this trace of what's hitting first. I see here's my A point, and they come together. So this is A point, first tooth coming together. And then right here is bilateral contact when I'm looking at my on my T-scan trace. So as one of those guys cross is contact. This is all slidey, moving around, getting teeth together at MIP. But I want to see what happens as the teeth collide initially, and how long does it take to get from one side to the other. And that'll tell you where your spikes are and how hard those spikes are when you look at your waveform of your tooth analysis. So when I see a baseline, when I see a JVA trace that I have that looks abnormal, then I'm going to have a test run, and then we're going to run at an altered position. And at that altered position, I'm going to look to see, okay, now what's going to happen to my waveform if I take occlusion out of the bat? If I change positions of the way the teeth come together, does that affect my jaw joint and my integral and my energy and my friction in my jaw joint? So it's very easy to see. And it's so the first easiest one I'm going to use is an end-to-end position to see what happens if I reposition the jaw and take a back tooth occlusion out. Do I change values? Do I change friction? But I want to see what's going on with my integral, my waveform, and is this a recapturable situation for the patient, or is there no change, or is it worse? That's an important part of this. I want to find out if I put them into appliance and I put them in a dictated position appliance, is it going to make my energy worse? Because you don't want to do that. You want to make sure that you're going the right best value to go towards healing. And do I need any kind of decompression when I'm looking at what kind of appliance I need to use for what kind of treatment I'm going to? I want to find the treatment direction that's best before starting my treatment. And so we'll use our JVA as a diagnostic tool and a verification tool with position testing, quick splint testing, or new splint verification, and document the changes going towards treatment. So here's this patient. As you can see, they got a bunch of squiggly lines right when they go into, this is into a closing vibration, okay? And as I said from before, I want to measure the value of my displacement. What happens to the value of my displacement, because that's going to be relative if I'm getting teeth coming apart, of what kind of change I can make with the system that's going on with it. And so my baseline, we have a 336 over 82. So we have a really bad scenario left to right. Okay, so we'll do an initial end-to-end test. So what happens if I just change positions? If I'm going to decompress and move that disc, that condyle, down the eminence a little bit, coming off the posterior compartment, what has to happen to the disc? And so the patient does the same test at an end-to-end position, opening as wide as they can, close, wide as they can, and close. And I want to see what has to happen and what's going to happen as they do that, and determine the changes of, is it going to improve the event, and how much is it going to improve the event, or does it make it worse? Because that's very important for me. So now here is this patient, same patient, the one we just looked at. Here's their end-to-end decompression test. Now we see on the right side, we bring it below, right at 15, but they just have this disc movement type of a thing going on because they have some cruddy artifact in there. And they also have this rolling partial disc displacement movement going on the left. So it drops this down to 65 from where it was at 300. Okay, so that's a big decrease, right? Is that easy treatment to do? No, it's not really easy treatment to do when you have to go that far forward if you're going into an orthotic. But it shows me that we can see some degree of change when we have decompression. And we have partial recapture and we have full recapture. So this shows me that I can get some degree of relevance when I go through treatment of maybe getting one side totally recaptured and partially recapturing the other side when she's a bilateral disc displacement patient. So this gives me encouragement that I can get some degree of help for the patient to get them healthier. Okay? So now I look at my changes between my end-to-end test. And the other thing I want to look when my end-to-end testing is what happens to my deviation deflection. okay? I still have a little deflection, but I still have this right here where I have my deviation starts to go away. So that's helpful. So I know that I'm starting to get some things to recapture. Now, I see a lot of patients coming in for revised treatment. They've been through splint therapy 1, 2, 3, 4 times. They come in with a baggie of splints, right? I love baggie of splint patients that come in because one thing I'm going to look at is say, okay, 1, why didn't this treatment work for them? 2, what was the treatment that was done? Were they compliant with their treatment? And I can measure the pre-existing splint that was there to see, okay, now I'm not going to reinvent the wheel. I'm not going to give them the same thing that they just had and charge them all this money and time that they're going to have to get into if I knew it didn't work the first time. So I need to design a better mousetrap and what's going to work for them the best way. So I love baggy splint patients because if it's a retreatment, you got to gain their confidence. And I want to prove why this other treatment didn't work. So that's really important for me. And then, so I'm going to rerun my test in the preoperative splint, determine what kind of pathology still exists, look back at my range of motions, their tongue positioning issues, and what is the splint doing to the joint. So here she is again, pre-op, 336/82. This is important to look at what their ratio is as well, because we know that there's not a lot of hard tissue going on here. It's getting kind of close though at 0.17, quite a bit of inflammation. And now here's their pre-existing splint. We have an enormous hit imbalance, occlusally, and they do decrease down to, this is 93, and then the right side recaptures back at 7.5. So we see a big change on the right, but we see a left side that's still pretty active. But the biggest thing that I see on my left side is the pre-existing splint that they have is actually putting them into a perforated state. That's a tear, that's degenerative, that's bone on bone going through. So their existing splint is actually causing them worsening, and there's causing them a further pathology because it's putting them in, inducing them into a tear. That's bad. And so when we look at that, we see, ooh, don't wear this splint. Because now that's actually, you're better not wearing anything than wearing this splint because it's putting you into an uncorrected position that's actually causing degeneration and a tear of your disc. Okay, this is why I run everything on existing splints to see how is it reflective to that patient and their existing condition. Is it making it better? How much is it making it better? Or is it making it, in this case, dramatically worse? The event's less, but it's putting them where it's perforated. So, important thing to look at. And here's our 0.42 and 0.423946 on the left side. And that's all this going into a hard tissue motion. So, not good. Now, one of the very easy things we can use is quick splint. Ann's out there. If you haven't experienced quick splint, this is awesome because it can be made in about 45 seconds chair side. And then you can put this in to do a quick test on the patient itself to see what happens if I just take posterior teeth out of play and change vertical. Simple test to run. And you can also use it in a positional appliance. You can say, okay, now move your jaw forward just a little bit because it doesn't take much. It costs you less than $20 and you can have an immediate gratification to see what changes for the patient when you're doing your diagnostics. And if you want to, if you're really nice, you can say, ooh, this does help you quite a bit. Here's a temporary appliance that you can wear until we can get your permanent appliance made. So definitely a big win-win situation. It can also be used as a therapeutic diagnostic tool for muscle inflammation issues from parapunction that you can have them wear over 2 weeks period of time, document grinding, document muscle relief. So it's very economical, very easy to use. You line it, you put it in, it's self-leveling position-wise. So let's see this particular patient where preoperatively they're 97.2, 11.8, a full 4A displacement as they open and close. And here they are with the quick splint. That's all we're doing. Pre-op, quick splint, looking to see what the change is. Pre-op, quick splint. Okay, pre-op, quick splint. If I have the patient at night, where would I rather have them? Over here, right? Because now I don't have a disc displacing and it's totally recaptured just by getting posterior teeth out of play and changing vertical a little bit. So this says, okay, parafunctionally I can control this patient from having them disc get popped off. So it's a big value for me to see what's going to go on. Now I can also have them come forward and I can check positionally. If I see not a huge value change of just my vertical change, which with my quick splint only, I can say, okay, I already know from my end-to-end test we saw a value change. Now come forward just a little bit on our quick splint. Now do your test. Open, close, open, close. Maybe they're in the posterior capsule and they still got to decompress. So if I have to do that, I know that if I'm making a nighttime appliance, I have to do a decompressive nighttime appliance, positional, and I have to do some kind of a daytime decompression appliance to get them to come off that posterior wall and move that jaw back to where it's supposed to belong to be able to be physiological again. So this helps me determine where I'm going to be going. Now, one of the really cool things we can also do it is, there's a lot of ways for us to treat patients, right? And one of the big things, a patient comes in, their goal is what? I don't like my teeth. I don't like my smile. It looks horrible. And you say, okay, Jim, I look at you here and it's like, yeah, I do see that you got an issue there with your smile because everything's breaking down and you got a lot of dentin showing and you got a lot of teeth that are breaking, and your quick thing is, how do I get my smile back? You can treat this with a splint, right? And say, I can work on your joint and get you splinted. You can do a living orthotic. You can bond it on the lower teeth, but then you still have some issue up here, right? So one thing about using our biometrics is now I can do active testing. Can I get this patient to go into treatment where I can get temporaries in his mouth, use his temporaries as an orthotic, as a living splint, and still rehabilitate his jaw at the same time to give him a new smile and temporary and acrylics? Or do I have to go into removable appliances to get him back where he needs to be? So here he is pre-op 3A. He's a PDR 3A. He's a 50, and it's this left side oriented, right side disc movement leading to a partial displacement. And he's got inflammation going on in the disc space. So when we run his end-to-end position, it totally recaptures. Okay? I say, okay, cool. We know it's a recapturable event. I can get you off. You're not going to be a 3A. I can make you totally recapture back to normal again with a little bit of disc movement. Okay, cool. But I can't restore you here, right? I can't restore him end to end. That's going to be impossible because once he gets pressure, he's going to seat that condyle. That condyle is going to seat and he's going to enter open bite if I do my aesthetics, my restorative care. So I want to see what can I compromise with. So I'll put my quick splint on as a deprogramming test. Just changing vertical. Okay, take him out of over collapse because he lost dentition. He wore his teeth back down. He over collapsed. He causes a partial disc displacement because of over collapse and wear. And so when I change his vertical as a quick split, you see I'm actually better with my quick split than I am end to end. Jump for joy and say, yeah, hallelujah, hallelujah, because now I can work with this patient to say, okay, what value can I make you at? And I can get your bite registration, get your wax up done, get acrylic on your teeth, get my bisacryl. Or actually, on these cases that I'm going to have them in temporaries a little bit longer, I use Visalis temporary material from Kettenbach. They're right out here. That material is dynamically hard. It'll go through your case. You can run your case for 3 to 6 months with Visalis and it won't break down on you because it's a compomer. It's not a regular bisacrylic. It doesn't wear the same as bisacrylic does because it's a composite type base. So it'll last a long time, and it's cool because you can base polish it. You don't have to add glazes to it, and it'll stay polished just like ceramics does. It's a much, much better temporary material. So check it out. It is dynamically hard though, so it's really hard material. Great for these long-standing temporary patients for doing rehab. And so when I look at this, I say, okay, cool. I know that changing this, I can get you back to relatively normal. This is just a little tiny disc movement. We're cool. So then I'm going to say, what do I need to functionally build you at to restore your guidance and make it so I can restore aesthetically of where your jaw needs to be with our treatment. So I'm going to use a composite ball type bite technique. I'm going to put my base materials in, and I want to put composite stops in here to get it so I can do active testing at the vertical that I want to make them at. So before I take this bite for my therapeutics, I'll work them up and I'll laser my joint to remove any inflammation that's there, remove my engrams, so I'm going to deprogram him with the laser, wearing the quick splint in place to get rid of the muscle engrams, get rid of the inflammation in the joint space, and it takes a long time. It takes 3 minutes per side. Unlike 2 weeks if you're going to be wearing them at home every night. So I like speed of treatment, getting them into records as fast as we can to get wax up done to get them in control. And then he can wear that quick splint at night to get it so he can control his parafunction issue to not get worse. And I'll wax him up and get him to go into treatment. Okay. So now here's my ball bite restorative position. And all we are is we're just at disc movement. Now we're even better. We're at 9.3, 7.6. So we're at just a slight disc movement type position with our corrected vertical position in with our ball bite. Easy to check, easy to test. Now I've already measured out. This is where he needs to be vertically, aesthetically, to rebuild his teeth. Let's measure it before we get it to wax. Let's measure it before I cut any teeth down, and let's measure it before I get him into his temporaries to restore his smile and use his temporaries as a functional orthotic to rebuild this jaw joint and let it get firm again. It's a win-win situation. He gets smile and he gets his orthotic in the same package. But the only reason I can do that is I'm going to test his functional position so I don't have to do a lot of fiddly work with his temporaries to say, ooh, I got to grind this down, I got to grind this down, I got to grind this down. I can get it right where it needs to be the first time and not have to really worry about a lot of disc squish movement and other pathology that's going to come on, because I've already told, his joints already told me where he needs to be when I look at my biometrics. So this is killer, this is cool, this is what we want to see with our treatment, okay? And then that's his smile done. Going from pathology to temporaries to finish in a 3-month period of time. So that's what we want to see. Okay? And so we'll look at bite position testing. I love the composite ball technique because it gives me control and I can hold position. And if you have a small AP change that you need to do because of decompression rotation, or if you have a situation where it's just a vertical correction, you can do it with composite. And this is philosophy independent. I don't care what philosophy you practice. If you're a CR dentist, if you're a neurophysiologic dentist, if you're a neuromuscular dentist, whatever occlusal philosophy you have, you can use this technique, you can measure it, you can put it on your biometrics and make sure that you're getting to the position where that patient's physiology will withstand treatment the best way possible before you get to treatment. Even if it's going to be fixed therapy or removable therapy, it's going to help you test it. Okay? And how I get there is a multitude of ways. I can use it as functional testing with my aqualizer. I use gradient sticks as my leaf gauges now because it helps with pitch yaw roll. Everybody knows what a leaf gauge is, right? You know, they got that plastic leaf thing that's about 10 millimeters wide, and you stack them up to get the DAC teeth to come apart. Well, the problem with that is you can induce a pitch yaw roll rotation to the jaw from the anterior to posterior. The smaller orbit you have as far as a round cylinder reduces pitch yaw roll torque to the jaw joint. So I much rather set my occlusal or vertical positioning with a round gradient stick than with a piece of plastic. So I like that better. I'll use this for my quick split for functional testing, or you can just decompress them and use a cotton roll. This induces more failure, but you can still do it if you don't have a half-cent stick that's in your office. But I like this. Works really well. So what I'll do is I'll go through, I'll deprogram the patient, I'll laser them, I'll put my stick to where I get posterior opening, where I don't have any collisions. And I'm doing whatever I need to, if it's going to be a neuromuscular technique with my tensing, or with my laser to do a neuromuscular bite with laser, or if it's going to be a positional type of a bite, or a CR type of a bite with my stick to make sure I don't have posterior influence that's there. I'll put in my Futar D bite registration material. Anytime I'm doing an open bite, I'm using the hardest substance that I can that's easiest to use, and that's Futar D. It's a 97 shore hardness, so it won't compress when you mount your models, or when you go through it, you won't get flex in it, and it's easy to trim. So I use Futar D, the red, fast. I want this setting fast as I can. Great material. And then I'll come back in. Once I have that set, I'll put my composite pad up front, and then I'll put composites in the back. I want to have them tripoded so I can have position. So if this is a case that I have to have a little bit of AP change because of a unilateral compression of the jaw joint, and I'm recapturing that and I need to hold them in that position, I want to make sure that I have this set, and then I'm putting composite pads on the occlusal surface of their first molar, here and here, because I want to make sure that I have some degree of stop that's going to be there. If I leave my Futar D bite registration material in there, it's hard because the tongue can hit it as they open and close and open. It can catch their cheek, it can catch their tongue, and the Futar will pop out and it dislodges and you get a weird reading. So on any of these tests, I come back and I tripod it with my composite and then my composite. And that makes sure is that if I have a corrected AP position or if it's just a functional position, I can test this and I can run my tests on it to do any value change I need to document my joint before I go into that active treatment or records. So composite ball registration, hold it and then test it and make sure that you're allowing the functional joint anatomy to work right and the muscles to work right. Okay? And there's the technique, composite, flowable, cure it, index it, test it. Okay? So let's look to see what this particular one is. Here's a DDR. It's a PDDR going in on its bilateral. And then here it is, bite registration going into a functional arena. Going, I'd much rather build this case here than there. Sorry, than there. So here's the difference. Corrected bite registration. Okay. Here's pre-op. They still have this. You know, that big deviation. So we know they're still coming on and off the disc. And then the disc is coming on and off. Corrected bite position. I still have a little bit of movement here. A little partial blip, which is a partial displacement here. But now look at this. I've regained normal as far as range of motion. I don't have a deviation. I don't really have a deflection that's there. Okay? So this is important for me to see that if I'm going to be taking a position, I can test it to make sure that position is going to work for that patient before we go to restorative means. We use this a lot. We have a couple orthodontists. We use this a lot with our ortho patients when the patient has a partial or full disc displacement and we're doing vertical correction on them. We'll use this same technique to determine where the AP, where the rotation needs to be, hold them with turbos and composite pads, and then my sister, my orthodontist, moves everything around that position so I can test it before we go there to make sure little Johnny's joint's going to be in its best place as we move teeth around as well. We use it for all our functional dentistry, our rehabs, our cosmetics, and our ortho patients. And we also use that for split determination analysis to make sure that before we design our split's going to work the best way it can. So it's a great technique to test it before you do it. Okay? So when we have our new split, so we've gone through the whole process and we've saw what our baseline was. We've done our functional testing to see where are they going to be best to the scenario that we're going to be. If we're going to be going to an oral orthotic, now I'm going to deliver my oral orthotic and I'm going to check my therapeutic position, my orthotic, and do whatever kind of adaptive change I need to as tissue resolves, as tissue recaptures, as tissue regenerates, and as tissue heals. I want to make sure that I'm going in the best direction. So we're going to measure my appliance when we deliver it to see where are we now with our appliance. So here's delivering our anatomic decompression appliance on that patient. We analyze our nighttime appliance to see what our value was. And then so here she was preoperatively. Her new day appliance, a dramatic reduce. And this is the same one I showed you before, that when her existing appliance that she was in, because she was a splint O-bag patient, she came in and that was a 4.8 as far as what her ratio was. Now we got her off that perforation, now we're at an 0.6. Okay, I already know that this appliance is going to allow her to get off that tear where she's not going to have that perforation of the disc and have osseous degeneration, so I can get healing now because I'm decompressing in the right area, unlike her other splint that she was wearing that was inducing her into a tear pathology and degeneration. So I'm going to prove that I'm going in the right direction towards treatment. Once I've gone through my treatment, then I'm going to do a mid-course evaluation with my joint vibration and my biometrics to see what are my changes, what kind of corrections do I need to make, do I need to add any kind of treatment towards phase 1 therapy to get better correction, and determine what kind of phase 2 therapy is going to be needed for the patient before I get into MMI. And in her particular case, here's her mid-treatment eval. Same trace that we're looking at. Remember, she was at 336 before and 90-something before, and now she's down to 34,672. And her values, her ratios back. We don't have that perforation anymore. And so we're moving her into a disc movement leading to partial on the one side and totally recaptured on the other side. So when I'm at mid-course, I'm pretty cool. But now we have to go back through here and look to say, okay, you know, where are you now without wearing your splint? So this is where rubber comes to the road to find out where are you with your treatment. Okay, I can see I still have some occlusal imbalance issues, and now I look, so she's not splinted here. She's braced on normal tissue. I'm close. I'm close to where her adapted position is going to be, to where MMI is going to be. So now I can prove when she's in her splint, she's here. When she doesn't have a splint, she's here. I'm relatively close in my values. So I know I'm close to MMI. Go back through all your normal stuff. Does she have pain? Does she have any opening? What other, all the stuff that you went through before, what do you have now? Or is there still some resolution that you need to do to get her at MMI to get the problem to be able to treat and accomplish, and what her goals are. You know, one of her goals was, I want to get this as best as I can, and I want to try to reduce as much noise as I can. Remember I said, I may be a noisy doctor, but I'm not a noise doctor. But there's ways that we can treat the noise to get it to start calming down. So now we look at her split, and we're discussion on her. This was done a couple years ago. We did prolotherapy back in her joint space to help get more fibrosis, get more tissue adaptation, and get more tissue growth to quiet down some of that noise that she was having. And now look at where she is splint-wise at MMI, post-prolo. 3 injections prolo. I've got her down to normal. No more disc movement, no more partial displacement. We're looking cool, okay? Now we look back at her. This is MMI test, no splint, same time. So I'm going to look now at our MMI adapted tissue after prolotherapy. Okay, 10 and 9.2. This is headset on wrong. 10 and 9.2, post prolotherapy, no splint. But I have a wicked bite imbalance. I mean, like horrible bite imbalance. Because now, you know, she's got tissue that's regrown. She's got tissue that's thickened up because she was a bilateral disc displacement patient. Now we got tissue that's back underneath it, and now she's functioning on that tissue, so her bites change dramatically without the splint in. So how do I know that? Oh, I'll just run my test with my T-scan to see where her imbalance is. So here's her trace, right side imbalance at A point. The longer this stretch is before teeth come together, the more slide I have. So I have a pretty bad bite imbalance. Now we talked to her about, what's your phase 2? What do you want to do? Can I get your canines? Can I get anterior lift off? Do you like your smile? I hated this. She goes, no, I don't like that either. It's like little snake eyes looking at you like a piece of dice, you know? And she goes, no, I don't like that either. So we talked to her about, you know, what can we do? You know, are they happy? Where's their wear? Do they have wear in a dentin? If they have wear in a dentin, what do we need to do to help that? Are they going to have adequate guidance? Is dentin exposed? Do they have crowding, an airway tongue space issue? Do they have some nighttime parafunction issues? What if we're going to go occlusal-wise, what kind of balancing do we need to do? Can we get guidance? Can we get right occlusion time, disclusion time? And what other we're going to do, replace, what kind of restorations need to be taken care of? And then so now here she is, slide, remove, balance at her initial, this is at B point. And so we've gotten her bite balance back up again. Here she is pre-op, post-op after occlusal treatment. Kind of crazy, huh? She was able to get guidance. She was able to get everything stable. We had to replace a couple of posterior restorations that were poor, and she let me change her composite up on the front that I didn't like, which was kind of cool. But you know, what we have is when we get to that phase, we got to talk about their options, their goals. Sometime in this process, their goals may change because they start feeling better. Their pain is gone. Their function comes back, and they can smile again. Some of the patients go, you know, I didn't know how bad my smile was because I never smiled. And they feel better now. I can smile now. You know, you asked me that question a long time ago, that how do I like my smile? How do I value my smile? I didn't like it before, but I didn't care about it because I didn't smile. Now I'm out of pain, I want to smile, and I don't like my smile. Can you fix my smile? You know, those are questions that you have to ask, but you got to lead it on the front side of what their goals are. And as I said at the beginning, some of your initial goals may change as you start going through treatment, as you get through some different things. So if they can wean or not wean, you have some different parameters, and you got to establish what the goals and wants are on that particular patient. I love sunrises and sunsets, and I love clouds. And this is my kids' life. I took a picture of my kids coming down the road last weekend, and this was photography with an iPhone. It's just awesome sunset. Just love it. But we want to make it so the patient can have a beautiful smile, you know, and we want to be able to preserve that smile. We want to be able to, once we deliver that smile, we want to make sure that we can adjust their occlusion and get everything lined back up so they're not going to hit bumps and scrapes that are going to cause things to fracture. And so when we're looking at our initial diagnosis, I will utilize my T-scan on my initial diagnosis phase. If I see occlusal imbalance on my JVA, then I'm pulling my T-scan back out, and I'm going to go relative data on my T-scan to find out, okay, how bad is my occlusal interference? Now, as we go through our MMI treatment and we get this joint fixed, because this is my primary, this is my initial determinant of occlusion and my final determinant of occlusion in my jaw joint, and I get this jaw joint rehabilitated, now what's gone on with the occlusion? So I got to use my T-scan as a diagnostic tool in this whole apparatus to see where am I going, what can I do to get it where this patient can become functional and not dysfunctional with their bite once we've got the joint back relationable again. And so I'm going to look at my baseline and my habitual occlusion. I'm going to look for my document and my hidden slides. I'm going to see where my functional interferences are and my interferences coming to occlusion and my disclusion interferences to see, does this system work right? And if the system works right, how is it working with my muscles? Are the muscles hyperactive or are they adaptive? And this is going to help me when I put my EMGs in with my T-scan to find out where's the baseline for the patient. Are they adaptive or not adaptive? What can we do with this particular patient? So we're going to look at this and we say, ooh, we got something kind of gross here. And yes, folks, this is a 0.50. This is a broken condyle. I get a lot of broken condyle cases for some reason. I got quite a few of them that we've finished treatment. And this is one where she was a fractured condyle and she did not want surgery again. So I said, okay, cool. We'll see what we can do to work out. And we've done pretty successful with a lot of these cases. But she has a very severe breakdown of the right joint, and she's got, because the right joint's gone, now her left joint's going. And so we look back at this. Now, when you look at here, you say, I don't see a huge occlusal imbalance issue, right? Until you click on it and blow it up. And we click on it and blow it up, and the right side is engaging a lot faster than the left side ever is. And so when I look at this, initially I looked at it and I dismissed the occlusal imbalance until I looked at her clinically, and I looked going, oh crap, I really missed something when I looked at this, and I had to go back and look at my values of what's going on. And she had a really bad occlusal imbalance. And so when I put her back on her initial, so this is her initial centric relation bite, that's all she hit, folks. That's where she hit, and that's where she hit every single time. It makes sense, right, Ray? She broke her condyle. She didn't have a condyle there. She's collapsed. So when we have this, this is where it's going to hit. And then I look at my basic range. I look at my basic muscles of what has to happen. What are the muscles doing as she just comes into closure? And I'm seeing, are we equal? Are we adaptive or non-adaptive with her muscles? Now we look at her clench, and she goes to close, and yeah, she over clenches this. When she compresses really, really hard, she will eventually get some occlusion on the left side, but it's not very much. But it takes a long time. It takes a lot of force to get it there. And so she has hyperactivity or temporalis with unequal masseter force. So when I look at this, I say, I definitely have some hyperactivity of muscles that we got to take care of. And that's where you say, uh-oh, what do we need to do with the occlusion? Is the occlusion destroyed or not destroyed? And is it looking back at you like a ghost figure? Don't you love that? It's like, oh! That's nice PFM work. I love it. So we want to look back at our baseline. There's another patient. Let's look at her. Okay? So we have our values. So we have, remember I talked to you, say if I'm looking at functional treatment, I'm looking at my closing vibration. If I can reduce my closing vibration, what's going to go on with my treatment as I use my therapy? Can I decrease it? Can I decrease the off? If I decrease the off, I can remove force, I can remove tension, I can remove stress in the system and allow stuff to heal. So let's look at her, and let's look at her occlusal imbalance issue. So here she is, hard waveform stuff on the left, and then the right is a little bit lighter. And we look back at my initial contact on my T-scan, and we are left premolar interference coming to closure, and we are unbalanced between my masseters and my temporalises, and my right masseter is overfiring, trying to clinch from initial contact to get the teeth to come together. So I have hyperactivity, non-adaptive muscles here, and then my temporalis is going to fire back up on my right side too, because it's kind of trying to work and position it. As she comes back into MIP, hard occlusion right, imbalance between right and left, and inappropriate hyperactivity of the muscles between the temporalis left and the masseter right. Why? Because we're firing and firing. We're over-firing and becoming hyperactive because the muscles are fighting each other because they're trying to bring the jaw back together closure-wise. So I have a hyperactivity imbalance of muscles because of a bite dilemma, and we already saw that she has a joint dilemma. So what comes first, the chicken or the egg? I don't know. We just have to get the chicken to grow and find out what we're going to do in the end of it. You know, we got to make sure that we can rebuild this jaw joint. There's no way I'm going to touch this occlusion until I get this jaw joint back in place. Ever. I got to get this jaw to its best MMI adaptable level before I touch occlusion, or I'm going to be grinding and never get there. So, and I'm going to find out, are my muscles coordinating or not coordinating? So this is where it comes into play as What happens if I take the occlusion out of play? What's going to happen now? Now on her JVA, initially I don't see a lot of joint issue as far as change. I see a little bit of joint change just with the quick splint. But I want to look at what are my muscles doing now at my clinch with my quick splint in. That's a big difference. If I can take posterior pathological occlusion and I get her non-compressed and decompressed, the muscles start to balance back out. So this test is run at the same time. So this is not over a period of time. This is over a couple minutes of running a test, putting the quick splint in, running another test. So I want to find out now if she parafunctions at night, if I have her into a corrected appliance, what's going to happen to the muscles itself to get things to calm back down so she's not going to put over force and cause muscle irritation and pain. So let's look at another one. Another JVA, occlusal imbalance, okay? And then we see left side, right side. Left side's hard. Here's our trace. Here's our bite imbalance, okay? Remember we saw right side came in a little bit. Here's initial contact, the initial slide. Look at these. Now this patient, you can just get the wind across the room and say, now if I push on this muscle on your masseter and before you get to the masseter they go, ow. You know, you just get air on that masseter, they hurt. So we know we have a patient that's really debilitated by muscle because even at her first point in contact, she's off the board with her muscles because they're hyperactive and they're fighting. So this is one that we look at. So now we look at our poor occlusal balance. Now we look at her B point as she comes into closure. Now, isn't it remarkable? Her initial contact, her muscles are worse than when she's at compression at B point because she's back into that adapted position. So getting to closure, that means she's got a wicked, wicked bad joint and she's got really bad muscles. So when we look at this, so we have a really bad scenario going on with the patient. So let's see what happens if we look at her lateral movements. We look back at lateral movements. So she's got a non-working interference on the right side when she goes left, and she doesn't have proper guidance up here. So she gets in unbalanced masseter hyperfunction. Not good. When she goes into right lateral, she's all premolar molar and imbalanced hyperactivity of muscles. So we know things aren't right. So let's go ahead and see what our analyses are on quick splint. So quick splint at B point. So when she compresses at B point on her quick splint, now look at what the muscles do. So if I take vertical change and I take posterior teeth out of play, I can already see I can start quieting muscles down. So I can prove that in my parafunction device that I'm going to make for this patient, if I can measure it and if I can get him into an anterior only and take posterior compression out of it, I can get her muscle symptoms to start to decrease because I can prove it. I can measure it. If I can measure it, I'm going to also see where I need to go with this patient. Is this patient a decompressible patient? Do I have to put him into that nighttime decompression to hold him in position to allow the muscles to calm down? Or is it a situation where I can just go vertical change only on an anterior only type of appliance to see what my value is going to change with my compression of my muscle or my hyperactivity? But I want to measure it before I do it because then I'm going to be successful and I'm going to be successful faster. So here she is at B point on my test. Here she is at B point on my quick splint anterior only testing appliance to see what are my muscles going to do when she compresses or if she goes to parafunction. I'd much rather have her here at night than here at night any day. Wouldn't you? I know I'm going to get muscles to calm back down. So that's how I'm going to use my JVA and my T-scan in coordinates on my diagnostics to see where is my treatment need to go to get corrected to get where we can be. I'm going to be able to get through this because we're going to still do our hands-on. Gina, I'm going to go through basic laser fast. Okay? So when you think it's safe to come out of the water, it may not until you have a laser. Right, Ray? The best effective management of inflammation and pain. Okay? Why MLS? Why now? Because a lot of my patients come in with pain. Inflammation drives pain. They can have myogenic and neurogenic tone issues. I want to make sure I get speed of healing going on, and I like to decrease meds, and I like to get fast patient comfort. Now this is a BS meter because if I go to the patient and I say, where's your worst area of pain, and we quantify that pain, and I shoot that pain right now, I should see at least a 50% reduction in pain in that initial shot. If the patient goes, oh no, it didn't change at all, I got to wonder, really? what's going on with them, what else are they looking for. I've had this where I've done that and the patient goes, well, that's okay, what kind of drugs are you going to give me? I like to treat without meds as much as I can. And I don't want to have that medical model of, let me give you this medication, this medication, this medication to feed this addiction that we're starting for you to manage your pain. If I can treat it without medications, I want to do it. Okay? And it works on the 808 and 905 with continuous and pulsed emissions, and it mitigates that cycle where the waveforms get paired at the optimal cycle to get best penetration. Okay? And so it works really well. The 905 works on your mitochondrial respiratory chain in the primary axis of the complexes of 1, 3, and 4, 1, 2, 3, 4, and you're increasing the ATP production to accelerate the healing process. The 808 works on the secondary absorption to also increase the mitochondria to start growing, get the cell to heal from the inside. It works really, really well. I've had great experiences with this throughout its time frame that I've had it. And I used other lasers before. This one just plain works better, faster, and you see better results with it. How do I incorporate this in my practice? We have build procedures and I have giveaway procedures. The build procedures really pay for it because this thing's running all the time. The giveaways gives me treatment. Because as Ray said this morning, it says getting that patient to say yes, getting your conversion rates. I know my conversion rates for all my TM patients that come in, they're 99%. And they're 99% on day one when we do our consult. You know why? Because I give away, where is your worst pain possible? And little Miss Jones goes, right here in my jaw joint, honey. I treat that and I say, how much change is that? They go, that's remarkable. It's that wow experience. When they have that wow experience, and if I can remove that pain now that they're here for, if they're their immediate gratification, the patient's going to say, when can I start? That's huge. When can I start? Do you want to start today? Yes. Because if you can make me feel better like that now, I want to feel better and heal as fast as I can. Even on those patients that you have to get their trust back because they have 3 or 4 splints that they have in a bag. They come in and see you, but none of those other doctors were able to treat that immediate gratification of where is your pain now, and let's treat it now. So huge selling point, because this just gave me a $10,000 TMJ case. Yeah, we like that because they want to start now because they feel the difference. They feel the pain. So you can also still go back to regular injections, and you can talk to the patient about trigger points or injections. Do you want that, or do you want me to hit you with a light? Most patients say, let's go light. You know? So I use this, and we're going to talk about this when we do our hands-on approach right now in 5 minutes, that we're going to deprogram with the laser. I'm going to de-inflame and deprogram. I'm de-inflaming the joint space, and I'm de-inflaming the muscles to change the engrams so I don't have pathological engrams of muscle movement as I go through my testing and as I go through my positional. Like if I'm going to be taking a bite for an appliance, taking a positional bite to decompress. Anything where I'm going to be taking and I'm going to be adapting my position for any kind of treatment, I want to have non-pathological engrams firing so I don't have pathology induced into my position that I'm building. And it's a triangle, teeth are apart, decreasing inflammation, and this triangle approach will help us change the environment to get it so we can get it, and it's 3 minutes per side. So here's immediate change in the joint space. So let's look at it. This is pre-op, 27, 29, and then post-op, 22, 16. All I did was laser and run a test. So we see a change. We see disc and we see tissue changes. That's what we want to see. So another one. Here we are where we see preoperatively 26. Both of those are partial disc displacements, so 30.7 and 7.8. And then when we see a 14 and a 10. So we see line and variant changes that we're looking at as far as discs that go on. When we're looking at our triangles, we look at our triangles. We're going to hit the posterior capsule space, the coronoid process. So we're going to cover over where the masseter insertion comes through and where the coronoid process, where the temporal tendon inserts. That's a very, very important part because that's majority of those patients. When I say, Miss Jones, where's your pain? They're either pointing to the masseter or the insertion of the temporal tendon. Okay, 90% of the times it's those two areas. And that's going to be very helpful to help get that out. And then I'm going to that bulge of the masseter. And so we're going to hit those 3 spots. They're going to split that time up in 3 minutes, a minute and a half to get all of those done. So 3 minutes per side to get all those spots done. And so where we use this also in dentistry is I'm going to use it in all my chronic TM patients, muscle deprogramming, headache treatment, tension management, candida, orthodontic acceleration for our orthodontists that are here, post-extraction, huge for these two, because when I take a tooth out, I'm putting something back in it. I'm either grafting it, preserving my sight, or I'm putting an implant, or I'm grafting or putting an implant, something that's there. I want to get rid of inflammation and stimulate healing as soon as I can. If I can decrease inflammation and not let inflammation start, the body heals fast. They don't need the drugs. They don't need the pain. They don't need the narcotics, because I can decrease it before it starts and they can start feeling better. And this also speeds up the rate of healing and bone change. So it's a big, big change. I'll use it for a reversible and irreversible pulpitis treatment. I hate root canals. So if I have to get them scheduled over to the endodontist and it's an irreversible pulp, then I can shut down the inflammation down in the bone at the apex, and I can get it so they can feel better. If it's a reversible pulp, I can get rid of the inflammation and their pain goes away and they don't need a root canal. So it helps me with my definitive diagnosis on those ones that I can't quite see if that's really going to change or not change. If it's just an inflammatory process, we can change it. Mucositis, any kind of a mucositis type of situation going on with soft tissue in the mouth. The one I love, which I love to talk about, is vertigo. I developed settings for vertigo to be able to treat vertigo immediately in your office to get it out. It takes 3 minutes total time to reverse most cases of vertigo that come through your office, and it works phenomenally. And we also use it for any kind of injection management for patients for postoperative discomfort. To learn more about MLS treatment, you can go to my website and go to my YouTube page. And this just launched as of last week. So there's more content getting put on it every week. We're shooting more tests and we're shooting more videos as far as what can you do with the MLS laser, and then what is the technique to use with the settings to use to apply it into your practice. So it's being constantly uploaded with videos, fresh treatment, fresh ways to go every single week. So go subscribe to my page and we can go through and you can start getting some good information about the laser, of how to utilize it in different settings for your patients in your practice. And if you have certain ones that you say, hey, what about this? Send me an email and I'll most probably be able to answer it or shoot a video on how to treat it. So that way we can adapt that. So it's a good training tool for your team and for yourself to utilize the laser. So we're going to talk about hands-on now with Gina. Who has a pop and a click? All right, cool. Can we use you as a guinea pig? Cool. Let's go. I'm going to have you jump up front here, and we're going to flip the monitor out. And so while she's getting the computer up and getting that going, we're going to do a couple things. We're going to do just like as my patient comes into my office, okay, where we're going to do our baseline biometrics. We're going to determine if the patient needs decompression. We're going to do an end-to-end test, a quick splint test. If we see that we need to do decompression, we're going to do a quick splint test edge to edge, and we're going to do bite position testing. I have all the stuff. We're going to take her bite, and we're also going to, if we have time permitted, we'll MLS deprogram her, and we'll also run our EMG evals as far as the way her teeth come there. This is if we can get to it in our time frame that we have, but we want to get through all this as far as a basic diagnosis to kind of see how do you use it, how do you do position testing in your practice to get the best early diagnosis that you can to go towards the right degree of treatment. You need a do you have an US do you have an HDMI? Cool. All right, Elizabeth. Do you have pain? Yeah.
I actually didn't wear my splint last night.
You didn't wear your splint last night because you knew you were going to be a guinea pig? That's awesome. I love
Well, I
compliance
actually
like
wanted
that.
them to try the laser.
Did you bring your
afterwards.
split with you? Do you have it with you?
I have something with me, but it's not my actual splint.
You have something. Okay, that's cool.
What do you want to do first?
I want to do range of motion,
Okay.
then velocity.
Oh, you're
So you do analog range of motion, then you're going to do range of motion. We're just going to, do quick split. I'm sorry, do quick. JVA quick, and then we'll hook her up to here and we'll show the difference between JVA quick and JVA JT. And then we'll go ahead and positional. We'll quick splint it and do all that. So let me see. Open and close, open, close, open, close, slide forward, open, close on your front teeth, open. Are you locked there? Close, open, close. Is your jaw where you used to lock? No? Do you have pain here?
Not so much because I do some exercise.
Okay, open and close. Pain there? And open and close. Pain there. Clench. Is it discomforting here?
Not so much.
Here? Clench. In here?
Not so much.
Not so much.
But I also get Botox in my nostrils.
Oh, okay. All right, cool. All right, so let's run JVA quick first. So we're going to compare it. We'll see what it looks like. Where is she?
51.
51. So as I said, in my office, we run JVJT on everybody as our initial baseline. The only time I run my JVA quick is if I'm doing test, like split test, quick split test, stuff like that, just to see where they are comparison to where they were baseline as we're going through our treatment. And we've even got to the point now where when we're doing those, we're putting JT on it because the information that I get on that is so valuable when I can see all my documentation of my range of motion. I am big into my change of range of motion because I want to see what it's doing and how that jaw is completely working with the hard and soft tissue. So 51, 0 deflection at maximum opening.
All right, so what I'm going to have you do is you're going to bite down on your back teeth and you're going to open as wide as you can for me and you're going to tap your teeth together so it's not fall. So we're going to do this about 5 or 6 times. Do you have any questions?
Have her bite on her back teeth.
Hold on, bite down on your back teeth. Open wide, tap, wide, tap. All right, we're going to do it now. Ready? Wide, tap, wide, tap, wide, tap, wide, tap, wide, tap, wide, tap, wide, tap.
I love it. Cool. Right now, this is where the value of a jaw tracker is. Because she has all this coming into closure. No, not yet. We'll review, run this, and I'll review while you're hooking her up to JT. But this is, we already know. If I look between tooth contact and tooth contact, is this normal or abnormal? Abnormal. Okay, we have some big spikes on the opening and the closing. So we already know we have some kind of displacement with reduction disorder going on. So we'll quantify it. We'll review it. We'll see how bad it is. So go ahead and run end to end. So if we're looking at our value, I'm doing it this way just because if you don't have JT, you can still see how you do it in your office. JT is a big advantage for us on cases like this.
Ready? Wide tap, wide tap, wide tap, wide tap, wide tap, wide tap, wide tap.
Okay, her time frame's off a little bit here, but one of the things I want you to pay attention to this is when you're doing a positional test, and they haven't opened and closed a few times as a test model, your first 2 tests on here are going to be relevant to where you were on your pre-op, because sometimes if you're decompressing, it takes 2 cycles to get where that tissue stays back on if you're doing a decompressive test. So I want to disregard those, and I'm going to look more at this data here, because that's going to be more representative. Where is she when she's positioned? Okay. All right. So let's go ahead and you can. We'll just hook her up.
Okay.
Yeah, and we'll do range of motion first. While you're doing that, I'll go to review mode. It's going to take you a minute. So let's go to review mode really fast. Did you save any of that?
Yep.
Okay, cool. So that one's edge to edge. Let's go to file. Let's go to initial. It's open already.
It's on the bottom there.
Yeah, I didn't see it. Sorry. Is my fuzzy head in the way? No. Okay. So when we go back through and look at our review mode, let me get rid of this other one. Hold on. I want to bring it back up. It just separated on me.
Doesn't want to come up for you? Oh, there it
No, it's separated on me. All my boxes did. There we go. There we go. Come on. Okay, so we know she's got, this wide opening vibration, both sides, and then coming into closure, she's got a really pretty wicked event going on.
Hitting it when you're biting.
She's pretty close to mirror image.
Yeah.
I'm doing what we call cheat masking because her event is really close to occlusion, and I'm trying to keep it out. Looks like I did okay. Okay, so when we look at that, she was close to a mirror image, but not quite. Part of it is noise coming across, but the other part is not. So when we look at this, she's a bilateral 4A. When we look at that, looking at her waveform, so she's a disc displacement 4A, 4A, coming together. And good opening, coming to closure. The cool thing about this is it's his late displacement. So late displacement's good because this is something that if we go to functional treatment, we may be able to reduce more of it. Her pickup is a little bit later though, where she reduces back on. But from what I said, remember, I'm concerned when I'm doing functional treatment with what can I do to change this? If I get the off to get less in value, to get less in integral energy, and to get less in torque, then I'm going to have better results with my treatment if I can change the off. Because if my off goes away, as far as the displacement goes away more, the on doesn't have to come on as much because you don't have so much tissue damage that's there. Okay, so we already know this is her baseline. She's a bilateral 4A. Yeah, go ahead, run your tracker. So this trait, she's perfect to show you why a jaw tracker is going to be so important on cases like this, because you can really separate your data out of where and how bad the tooth contact is with where the disc comes apart on the exact position of where that event happens, where it does come off. Questions while she's hooking the tracker up?
At what point do you consider a measurement at which they will, before they reduce onto the disc, at what point do you think they'll be trapped behind that disc? In other words, is it the 40 millimeters and we kind of commonly throw out 35 millimeters?
I'm shooting for 40. When I went through I went through a bunch of range of motion studies just lately, and there's a study that came out of Brazil that looked at adults, adolescents, and children as far as range of motion of pathology versus normal. And it was a big study. And it came up with, that's what those values that I came back up with was 40, 6.8, and 5.5 as far as maximum, normal maximum opening, right to left lateral, which was 6.8, and then the 5.5 protrusive. That's where that came from, it's a mixture of all the data between kid, adult, and adolescents. And if I can get them to 40, that's where I want to be, or 40 and above. The medical model, as far as what's approved in medicine, is 36. Do you know why? To get a tube down somebody's throat, you need 36 millimeters opening to get the tube in, intubate them. So it's for saving their life. That's the only reason the medical model says normal for a jaw joint opening is 36. Dentally, when we look at our averages, 40 and above is what normal is for adults.
What's the thoughts on somebody that opens 15 millimeters?
Is it a soft or hard end feel?
I guess it would be, that's my question, but she says it's locked.
Yeah, so you run your test. You run your jack screw test with your finger and say, okay, open, open, open. If you don't have a laser, you can use Gerber spray and stretch to spray the muscles down, to ice them back down to see if there's a spasm, to see if you can open it back up. And you stretch them back up and you see how far can you get to open. It may be a total muscle spasm issue and it's a tissue lock, it's a muscle lock instead of a joint lock. Or it could be both. They could be spasmed out, they can only open 15, but when you stretch them back out, you hit a brick wall at 30. Still pathologic, still too much. Usually when they're that low on 15, that's a locked disc. But generally when they're that low, it's locked. Yeah, and they probably have muscle spasm that goes with it. So that's usually my skinny on ones that are 15. Because they go into severe muscle spasm because they're just always fighting. Any other questions there before we're hooking this up? Okay. How we doing? See, this is why I delegate all my traces in my office, is because as they're running through all your data, and my assistants will gather all my data. So they know what to do as far as when they put the headset on. They know everything that I want. They're going to run my range of motion, my velocity. They're going to do my analog measurements. They're going to put them down on my terabyte, on my ruler. And so I'm going to have both that are there. They're going to tell me this is what we have. And so they delegate all that to my assistants because I can be somewhere else. I can be doing productive work. I can do some kind of production, do something else while they're running all this exam. Then I come back and read the exam and go through and ask them and do their questionnaire. I already know what I'm suspected I'm looking for. Then I got to put my pieces together clinically. That's when I start doing my clinical evaluation, my exam, put my hands on my patient, and I can already have run my biometrics ahead of time to make sure what am I looking for that I need to look for. If it's a TM one, I've already seen my CBCT. I've already gone through my volumes in my CBCT to see, does my CBC correlate with what I'm seeing on my joint? Does it have a hard tissue? Does it have a disc that's displaced? Am I suspecting a vertical position change in the joint, an AP change in the joint, or one side's collapsed or not by looking at my FFT level? So I'm going to look at all that data. Then when I'm coming to the patient, I have an educated guess of where am I going with this patient to get them healthy, and what am I looking for as far as in their values.
Sorry, my laptop is having issues. I'm not sure why.
Cool. That's always good on a hands-on.
Let me go grab one of the guys' laptops.
Sure. While you do that, I will let me do a couple things so we're ready to go with it. What kind of appliance do you wear?
Interior.
An anterior? Cool. Does it help your muscles when you wear it at night? Mm-hmm. Does it help your joint when you wear it at night? Mm-hmm. Cool. If you don't use it, you know. Yeah. So while she's...
I if I want to buy a laser, so I didn't know where it said you can do this.
We can laser you today. Cool. So while she's doing that with technical errors, I'm going to grab a couple things. The only thing my assistants won't do is they won't take a corrected bite. They let me do that because after I see my data, then we'll run the corrected bite to see what we're trying to recapture and what we're trying to look to do. But they'll make my quick splints. They'll get all my pre-op data as far as my baseline, my end-to-end, my quick splint value. If they see not a big change, then they'll do my end-to-end quick splint. So we can also see what that change would be like. So I can have lots of data when I look at it. When I come into the room, they've also run my EMGs, and they run my EMG values at baseline of clinch with cotton roll, rest, And then they also run it the same relax and clinch with my quick splint in place, so I can see what does it do to my muscles if I get posterior teeth out of play and occlusion out of play. So I can have all that data ready to go. That way all I have to do is interpret it and read it. Oh, I'm sorry. Go ahead.
No, close.
Okay, I don't want to spit on your foot. Open, please. Bite down. Squeeze. Open. Bite down. The cool thing about quick splint is it's self-leveling. That's all you got to do to make it. It's really, really easy. And this putty actually sets up. It's a little slower. I like the putty than the Futar D registration in it, or I like a Blue Moose. Something that's in the 80 shore hardness level is usually really, really good. When you get higher than in that, then it's too brittle. It's hard to get in and out. If it's lower than 80, 82, then it's a little bit too more flexible. So you kind of know what you're going to do with it. While she's still doing this, is one of the things we also use with our quick splint is I use it on all my my post splint phase 2 ortho patients that I'm utilizing if I'm using an aligner type of a tray system on the ortho patients, because the patient fires back up into muscle dystrophy issues because those trays fit like crud, you know. They're not designed for occlusion. And it does it so their parafunction at night with the muscles don't get hyperactive and they stay nice and calm all the way through treatment. Works very, very well to keep a muscle patient under control while they're going through their ortho. If it's a patient that's in a fixed wire situation, you can also do it. You just have to change them around a little bit, be careful with it. But most of those, I'll make a Holly retainer that has a discluding element over the top with thermoplastic beads in it, and that way we can control parafunction on that patient at night also. Okay. I will, I don't really want to take her bite position until I see things and laser her, because I don't want to cheat the results.
The projector is creating an issue for some reason.
Can I unplug the projector and get our data, and then we can just plug it back in and review it?
Yep, I just did, so now it's just restarting here.
Okay. Okay. Now open, close, open, close, open, close. How's that feel?
Good.
Okay. Other advantages of quick splint is when I do this test, the patient gets to go home with an immediate appliance that honestly doesn't cost me more than $20. And you can also start removing inflammation at night until they get their other permanent appliance. As I told you, immediate gratification. I want this patient feeling better. As I said, I get a lot of retreat patients, a lot of TM retreats, and most of the time when I'm reevaluating their splint that they're wearing at night, it makes them worse. And if I can prove I can make them better with this, I'd rather have them wear this temporary appliance until we get them into the corrected appliance. And our biggest goal on that is get them healthy fast. What can you do to get them there? And that's what we're after. Gosh, I don't want to laser her right now because I want to see what she looks like without lasering.
I apologize. There's something going on with the signal in here.
You broke it.
Sorry.
You broke it. Go ahead and you can just leave the headset on. Run JVA quick with the quick splint. So we'll just have a comparison data on it. Okay, here you go. You can put that in for me. At least we can get something run. You know, this is not supposed to happen, you know, at BioRESEARCH. And
Never happens. Ever.
But remember, who are we working with? Mike Smith, right? If anything goes wrong with technology or problematic, it's always, I am like the worst beta tester ever because if it will break, if it has any component to break, it will break in my hands, without a doubt.
Good timing, Bruce.
Luckily, we have Bruce.
Yay, Bruce. Bruce saves the day.
So it's right here, Bruce.
Everybody, Bruce. Yay, Bruce. All right, while Bruce fixes this, questions. Any questions from earlier? There's got to be a question. Ray, questions?
Oh, xerostomia settings. And you said you were going to, for the laser.
Xerostomia settings or mucosis or
Have you seen help with it with xerostomia?
I
You
see.
love tinnitus. Are you doing
So,
what are your settings and all that?
Okay, so let me go to xerostomia or mucosal irritation because xerostomia causes mucosal irritation. So mucosal irritations, I'm going at 900 hertz with the intraoral tip, treating the mucosa, and I'm scanning through, and depending on the area that you're going to be going through, you're 3 to 5 minutes to decrease inflammation. That's on the first run cycles. The second week cycles, I'm turning it down in my intensity. All this is run at 50%, okay? The only time I'm changing my percentage gate is when I'm doing a trigger point, and that's the only time I do that. But all the time I'm running it, all the other times we're running at 50%. And so on my initial, on the high inflamed patient, I'm higher hertz, less time. So I'm going to shoot it, you can go either if it's a fragile little lady or if it's somebody that's a little bit thicker in tissue, you go 700 to 900 hertz, 3 to 5 minutes, run through all the tissue on it. When you come back in the second week, so I'll do that setting on the 3 times that week and then come back. If they need extra treatment the second week, then I'm I'm down. I'm going to drop it down to 400 to 500 hertz, and I'm going to go a little longer time. Because once you remove the initial inflammation, you're going for systemic healing. So I want longer time, less energy to allow cells to get more activation. Initial treatment through, I'm blasting it to remove inflammation. Second treatment through, I'm allowing cellular regeneration healing. Now remember on the laser how it works. Your peak inflammatory interval is at 72 hours, okay? If you overstimulate the tissue, so if you hit it 3 days in a row, you're overstimulating the tissue. You gotta give them a break. Shoot it 2 days on, remove the high inflammation, let the peak inflammation value come up to that 3rd day. So on that 4th day, you treat it again. So you're going to skip a day after that treatment from your first dose. From your first to second dose, skip a day and then go to that next day. And you're going to see a big change in inflammation because you're going to carry that peak inflammation level back over a longer period of time because you're boosting it. Because it's like a bell-shaped curve as far as peak inflammation is at 72 hours. Your highest degree of anti-inflammation is at 72 hours. So you're going to boost it on your first 2 days. You're going to let it stay peaked out, and you're boosting it on its peak. And that helps carry it over further so you get better tissue results, better inflammation results, better pain healing.
So it's not actually treating the actual xerostomia as much as the secondary mucositis.
You're treating the mucositis. You won't change xerostomia with it, but you're going to change you're changing the effects of xerostomia from the mucositis with it. Now, tinnitus. You just said something about tinnitus. Tinnitus is a can of worms because some you can get resolution, some you can't. It depends on how much inner ear damage that patient has of what caused the tinnitus. If it's an inflammatory process because of the inner ear issue and the joint issue, then you can get good resolution with splint therapy and with laser therapy. And I didn't have that slide in here, but I actually have a slide on the whole mechanism of it. If you want it, I can email it to you. But it's of how that works, the whole mechanism. But tinnitus itself, I never promise my patients I will remove all the tinnitus. I tell them I hope I can remove some because of structural damage in the inner ear. And that's one of the big problems. But it's the same setting. That's usually a combination setting. You have to have them into an orthotic, and you have to be able to laser and remove the inflammation in the joint space there. We're good?
It was actually our mistake.
Yep.
Thanks, Mike.
We'll come back to any other questions there. What do we have in now? Take your quick spin out. Okay, hold on to that baseline. Tooth to tooth baseline.
Okay, bite down your back teeth. Want her to full range of motion now?
Yeah, range of motion. So when we run our test, I do full range of motion first. I want to know where they go, where they open, how much deviation, how much deflection. Then next one, they do velocity. And then the next one, they run their JVA regular tooth to tooth. Yeah. She has a little bit of headset on wrong.
Is she wearing anything?
Nothing right now.
Is she on a class 3 level?
No. What was your initial opening? She was 50? 51? Okay. Because I can see that you're off one side versus the other. I'm not too concerned with that. We can work around it. Because she doesn't have that much deflection. So. Okay, let's run it again, see.
Open as wide as you can. Left. Left. Right. That's okay, we'll reset. Ready? Bite down your back teeth. Okay. Open as wide as you can. Left. Right. For two.
That's that disc. You have to go set occlusion. Do you know how to set endpoint occlusion? Just do it again then. It's quicker. When she started, her teeth weren't together.
Alright, bite down your back teeth. Open as wide as you can. Close. Go left. Close. Right. Close. For sure.
There you go. All right. And now run velocity. She's got a big AP sweep.
Alright, so what you're going to do is you're going to open as wide as you can and close as fast as you can. You're going to do it about 5 or 6 times. Okay? Make sure you go through your corner. Bite down on your back teeth. Wide close, wide close, wide close, wide close, wide close, wide close.
Gosh, she almost scared me out of that. The reason I said this is not quite reflective is it starts at a slant all the way through. And yeah, the headset's still tilted a little bit. So she does not have 6 millimeters worth of deflection because it starts at 0 and then she comes straight down and then,
Mike, we just plugged this jaw tracker like 2 minutes ago. That's probably what it is.
yeah, that's fine. As I said, we're going to work around it. So when I'm looking at my velocity, this is where she's coming back on and she's coming off right in through here. So we're going to look and see where that is. This also corresponds right here at her crossover of where she's coming off. And you can see right here of where she comes off on the closure. Okay, the opening right there at the crossover, right there at the crossover, and then right there is where she's displacing out, and then right there is where she's coming back on. So go ahead and run baseline. Okay, so we already know just by looking at this with the amount of deviation, because we're going to discount she's not deflected. JVA JT, normal back tooth together. We call this a double crossover. Double crossover is usually simultaneous with a disc displacement with reduction disorder anyway. And she's got a big swing on her anterior to posterior in translation, which she's trying to move her jaw out to stay on the disc, and she comes back off the disc on closure. Some of these, depending on where this crossover is, if it's right at or before closure, you have to look to see are they a class 2 div 2 or class 2 patient, because they have to reposition their jaw back to get into final occlusion. So, but when you see this start where she's picking up right here, that's usually, where she's picking off right here on closure, that's late. These are usually kind of more adaptable when you see late displacements. So it's good because that gives you an idea. It's like I can be a little bit more productive when I go to my treatment, and I can say I'm going to most probably be able to get rid of most of your displacement that's there and pretty much eliminate a lot of it because it's late coming off, which means I still have a lot of ligaments that are holding that tissue on, and it's not coming off way up here. When it comes off way up here, I say there's less chance of you getting back on tissue and staying on tissue because you don't have ligament space that are keeping it, holding it on that closing cycle.
Do you think you could just open her vertical a little bit, keep her on the disc?
We're going to test that. And that's why we're going to do a baseline test with our quick splint, because all that is a vertical anterior stop appliance. That's why she's probably seeing results with her anterior appliance only at night right now. Make sure she opens all the way and hits her teeth together nice and firm. And sometimes to get a better reading, it helps to plug the headset into the amp box. It's just kind of crazy sometimes, but sometimes it works well. Okay, now that's a lot easier to read than JVA regular, right? Because now we see the delineation of exactly where tooth contact is, where this disc is actually coming back on here. So when I look at this versus where she was on her JVA quick, I look at this. This is late displacement, early reduction. When I see these, I jump around, I do a high five, and I say, cool, this is awesome because these are predictable. Because this is late, early. That's cool. The later it is, the earlier it picks up. The later it comes off, the earlier it picks up, the more effective you are with your decompression is going to be, and the more effective you are on rehabilitation you're going to be. So this is super cool. Edge to edge, please. So now all she's going to do is come forward a little bit. And she's going to open wide. Make sure you open wide and hit your front teeth. Open wide, hit your front teeth. Open wide, hit your front teeth. Cool. And now I look at this, I can just sweep right through it. So positional on her, because she's late and early, by just getting her off those back teeth, this is just going to be a disc movement, little wobble. Just even looking and scanning through the trace. So I already know by seeing that this is a recapturable or a recapturable case when I see that. It just depends on how we're going to recapture it. Now put your quick splint in, if you could please. I'll go through the data. Once we get all this, I'll go through the data analysis so we can see the numbers and you can see the waveform change. But is that easy treatment to do in a splint, having to have to come that far forward? It's not. It's tough. It's harder. It's hard for the patient to wear. Is it doable? Yeah, it's doable. But then you got to find a fine line of, now we see it's recapturable, where do we have to put them to recapture? Okay, so we look at this, and one side is recapturable. When I made that, obviously I had one side on a little bit hard. So you feel like the left side's hitting a little harder? Yeah, that's what that is. But the left side recaptures. This side still has a partial. And it's early, late. It decreases quite a bit. Now I don't want you coming all the way forward, just a tiny bit. Okay? So when I see that at her edge-to-edge position with tooth to tooth, she totally recaptured. All I want her in this position here is maybe because she's a bilateral disc displacement, she's back down, she's posteriorized her condyle just a little bit. So let's bring her just a tiny bit forward at vertical and see what this looks like. And this is going to help me determine when we take her bite of where we're going to go with it. If we're going to use a CR apex of force bite, or if we're going to use a phonetic bite to see what we're going to go treatment-wise. Or if this is an instance where you're neuromuscular, you can TENS them out, laser them out, and then take your neuromuscular bite and then check it. So when I look at that, that's even reduced a little bit more. When she came forward a little bit, you feel like you're hitting a premolar, right? No? Okay. So I look, because that normalized the bite. So we're just a little bit of pickup here. So I like that. So when I look at this, I'm going to do a phonetic bite when we run
Is
that.
there a box on that thing over there? On mine.
A box?
Is there, yeah, a little small black box on mine? Oh, do you have a? It's in the, on the table, a little black box, so if not, bring my purse.
You know, one thing my mom taught me is never ever reach into a woman's purse, because you don't know what's in there that's going to take your hand off. Oh, cool.
And this is phonetic.
Awesome. Even better. And you took the quick splint out? All right. Awesome. I love it. This is just like the patients that come in that have bags of splints. And then we see, is this beneficial? Is it not beneficial? I love this game. All right. Doesn't matter. She didn't open all the way.
You want me to open more?
Yeah. It's better. It's good. We'll see if we can improve her more. Cool. All right. JVA with appliance, or with however you want to call it. That's fine. Okay, so that definitely gets rid. She still has a little blip. So go ahead and you can still leave the headset on, and you can still, or just take it straight off, leave the magnet.
Okay.
And you can leave those bites in place.
Which one?
The one you have in there.
Okay. You like that one better than this one?
I just want your teeth apart.
Okay.
So you can put the quick splint in, or it doesn't matter to me. And I'm going to go through this data here while she lasers, and then I'm going to run a bite after she lasers to see if we can improve that a little bit. And then we'll show the value of what the laser's doing with the corrected bite positions and everything like that. But she's pretty close to this. She still has a little bit going on right there. So, but it's definitely improvement where she was normally. So what she's going to do is she's going to do a triangle approach with her teeth apart, and it's going to take her 3 minutes per side. And she's going to go 900 hertz in the posterior capsule, the temporal tendon at the coronoid process, and then the masseter.
Those are my cheap phonetic daytime clients.
Mm-hmm. I'm going to close these because I want to...
I saved everything that you want to.
Okay. I just hate all this stuff on the bottom of the screen where I can't see which one is which. Where it just says JVA Suite, but I don't know which I'm picking. Okay, so on Elizabeth, we looked at her JVA quick on her initial, okay? And we saw all this. That's kind of hard to disseminate, like where the waveform is and everything like that, right? So we already looked at it. We know that she was a 4A bilateral. So let's look at her quick splint forward. It's reduced all the way. So when we look at that, 5728 is totally it's reduced. Okay, cancel. There. No. So she's recapturable. JVJT initial. So this is a lot easier to read. Didn't quite have as much. Her second test didn't quite have, when we put her into that quick splint, it definitely made a little change to her.
It happens fast.
Huh?
It happens fast.
Yeah, it does.
If I wear a splint for like even 10 minutes, it'll make a big difference. In my
Yeah. Even that, because this isn't reflective of what your JVA quick was. She's disc movement bilateral just when she wore that for, it's crazy. That's actually really crazy. But it's disc movement still with a pickup because she has this, so it's disc movement leading to partial disc displacement on the right. And then, where is she with her appliance? Let's see, her JVJT edge to edge. So when I look at her JVJT edge to edge, and I look at her closing value, it's back to normal. So she's normal recaptured. When I look at her trace, she's less than 2 millimeters of her deflection and deviation. This 4.5 is not correct because the headset's crooked. And she's down to 5.841. So just that's huge with edge to edge, so we know she's totally recapturable. Edge recapture. So let's look at our JVA JT with quick splint. This is based quick splint when we know she's hitting the left side hard. I don't know why you're getting a, what is your N black line on your screen right there? What is your N black line on your screen right there?
I'm not sure. I've never seen that before.
Ray, have you seen that before? Right here, where my cursor is? You see this N, black box N? You ever seen that before? Yeah. It doesn't move. It doesn't move.
Click on it and see if you, is there a black box in terms of the metrics on the side? Click on it and see if you can get rid of it.
I tried. I tried on the other trace. It wouldn't go away.
Click in the middle of it and then delete. Delete. Getting rid of it. Scroll around now.
No,
Push it around.
it won't.
Oh, no, you can't see this now.
That's what I was saying. Is I don't know what it is.
It's a new update just to freak you out.
Black box one.
I mean, I know just about everything about this technology, and I don't know what that is because I haven't seen it.
Doesn't it say like N at the bottom there? What's
It
it?
says
Yeah, it
N.
does.
It says N.
N?
N,
Yeah.
as in Nancy. I don't know what it is. Okay, so you guys found something. I don't know what it is on JVA because I have no idea what that is. I'll have to ask Bruce because I don't even know if Greg knows that one. Huh. Okay. And this is the new update?
Yeah.
It's something in the new
Must be in the new update.
It's something in the new update, folks, I gotta learn about. Okay, so now here she is quick splint. Okay, she's 14-1 right. So she has disc movement on the right, left side's recaptured. So we're okay with a little bit of vertical correction. And then let's go quick splint edge to edge with JT. We did that one. I'm gonna forego that and go right to her edge to edge. What's her appliance? Her appliance is here. So here's her corrected appliance that she wears. And we're looking back at that same data. That's tooth contact. And she's normalized there. Oops. Who took your phonetic bite?
It's like self-made.
Well, you did a good job.
Thank you.
Because this is what we're after when we see our, results. So when I'm looking at that now, she's basically, it's the same as where she is with quick splint. It's the same as where she is basically edge to edge. It's just normalized, recaptured at disc movement. So that's super cool. So before you hook that up,
These are cool because you can make them yourself.
yeah, that is cool. So let's do one thing. We'll see if we can keep it the same. It's kind of hard to do better when it's normalized again, so that's good. But I'll still show you the technique of what we're doing. You still have that in?
Yeah. You want me to take them out?
Nope. I do not want her to take them out because if she does, she's going to re-engram. And she just did all that work to de-engram her. Let me see how much space I need. Wow, that's far you're open with that?
A lot or not?
Yeah, that's a lot. Okay. But it's working. You're not wearing that at night, just during the day?
I have it interior at night.
Anterior at night. Okay.
You can rest if you want.
That's cool. I'm going to see if I can close her down a little bit. As I said, I like round sticks because I can get rid of more of that pitch yaw roll. And we're going to see if we can improve her a little bit. Just, I don't have a cotton roll. Just leave it in. You got a cotton roll? That'd be great.
I won't like together.
Yeah, keep your towel. There you go. Cool. Okay, just swallow. All right, open. Okay, say 66,
66,
67,
67,
68,
68,
69,
69,
69.
69.
Close. I'm doing a phonetic bite. Open. Say 66,
66,
67,
67,
68,
68,
69,
69.
and close right there. But I'm trying to, she was like kind of jacked open a little bit. So what I'm going to do is now roll your tongue up to the roof of your mouth a little bit. And what I'm going to do is put bite registration to hold that. And then I'm going to put a composite pad to capture it. so I can do a functional test where she is now, is that it's hard to do a functional test with bite reg in it because when she opens and closes, it'll flip on her tongue, so it moves a little bit. And then we're going to test that position to make sure it's working the right way. I'd like to see if we can decrease where she was vertically a little bit because she was, with that other bite in there, she was pretty far open. But it's doing the trick. It's just, is she able to lean? Can you decrease her vertical and work on occlusion and hold her there restoratively? Okay, now open. Open. Right now, yeah. Open, close, open, close. Like that. You don't feel that pop at all, do you? That's a lot more. Is that more comfortable?
It feels a little far back, like here.
Okay. We'll check it. We'll see. Open slightly, slightly, slightly. Open more. Open, open. There you go. What I'm going to do is I'm going to put a little flowable. You don't have a retainer wire behind it, do you? Stay there. Goodness, it was way hot. And one thing about a composite is you can open, open, open. That's good. The bite's still there. If you do have a positional correction, it'll hold it. Okay, close into the bite. Stay there. Open. Just as a point of reference when you're doing that, and the first time the patient opens to cure that lingual surface, hold that position of the ball with your finger, because if it sticks to the top tooth, it flips, and it always flips back to the back of the esophagus, so hold it in there. At least for me, it does. Okay, relax, close. Here, I'll let you hold up. Now it's, can you hold more things in your mouth at once? Smile. Open. Close. Okay, open. And we're going to make a tripod for our bite test. Close. Relax your tongue. You are a tongue thruster, man. Mm-hmm. Do you do myotherapy?
Harder, you know, I will need in your.
Hard to answer, yeah. Mm-hmm. Stay there. I asked her if she does myotherapy. She is like wicked with her tongue position. Open. And close. Relax your tongue. And all I'm really asked after is the lingual cusp tip of the first molar to go ahead and capture it, open, just to hold position. And I got it on both sides. Okay, bite, open big, bite. Oh, there you go, open big, and bite, open big, bite, open big, bite, open big, bite. Okay, how's that feel? Feels okay. You might not be able to tell much difference. Okay, let's hook the headset up and run that, okay?
Yep.
So now we're going to check and see, are we still holding the recaptured position at a better vertical? If we're going to be doing any kind of other restorative care or transitioning her from a big positional splint to a more minor splint to be able to easier to wean off of. And I don't know if it's going to be better. You know, this is the part of dynamic testing is you don't know until you test it, right? This is where I think when we bring her back, when I do the phonetic test on her other phonetic test was way open. I mean, she was at least 6-7 millimeters more open than where she is now. And that's pretty far open as far as where she was. Let's see if we bring her back into a more therapeutic level as far as reducing vertical. Is this going to be better? And this could be a situation where she's got a little deep curve of speech, she's got a little bit of a lingual tip of her anteriors. It may be an ortho leveling case where you could get this through. But where she was before in that big therapeutic bite that she's in, I mean, that's really a lot to ask for if you're going to do ortho and move things around. Her dentition is good. She's not worn into dentin anywhere. You know, so this is one of those, is like, well, I don't want to be like putting glass at a vertical that big on her because she's going to look like a horse. Her teeth are going to be so big and so long. But if we can do it where I can minimize the vertical and still hold on to the disc space, it might be a chance where we can do some ortho movement and level it back out. And then we're off a splint all during the day, and all we got to do is just work on parafunction at night. Where she is right now, that might be an achievable goal to where she is. She's got a little bit of a narrow maxillary arch and a deep curve of speed with a little bit of lingual anterior tip, which does what? Shoots her and rocks her back. And it's what she felt. She says, yeah, I kind of feel like I'm back in the back space. Do it again, because pull the anterior jig off. She's hitting the anterior jig. Can you can use your fingers, just grab that composite. I don't have a burr to adjust that. And she was rocking off that anterior jig. That's what that weird bump is. Now let's see what it does. And as I said, I don't know if this is better or not. We'll see. Okay, not as good as her other bite. I'm going to do one other check. So when I look at it, I still have this going on. Just hit review. And I'm going to change that. Just drag it to that. No, the closing event. Right there. That's a double bump that she's hitting that pad twice. So click that. Click that. Click that. And click that. Okay. So it brings you to a 33.2. This is disc movement leading to a partial. The left side is still totally recaptured. So we are off on the right. I'm going to do one different test on her. Oh, my gloves are over there. Actually, her midline's the same. Yeah, it was just vertical change. She's definitely, she's hitting that one side harder. Does it feel like you're hitting that one side harder?
Left side?
Right side. No, open. Just stay open. So I'm actually going to change directions all the way. Right? Side forward, side back. Hold that. I am going to look at her. Let me see if I can do that and not have to do another futar. Yeah, open. Just stay open if you can. So what I'm doing is I'm going to go to a apex of force bite and see if just the vertical change does like what we see with the quick splint. And close. Roll your tongue to the roof of your mouth. Just gently close. And just gently squeeze. That's good. And open, open. Bite, open, bite, bite, open, bite, open, bite. Now let's just check that. Okay. Just the bites off a little bit. Go ahead and save it. Huh? Did one dislodge? No. No? Okay. Just go and drag it right to the before closure. Okay. That's all that I'm looking at, those big spikes are just, she's hitting the right side a little harder. So just pull it, sheet mask it. You can grab it. No, sheet mask, just right. There you go. Okay, now go cheat mask that one. Keep going. Keep going. When you see black, back it off. Back it off. There you go. And there you go. Get it? Okay. So she's periodic. So when I look at that being periodic, that's just basically that's a CR bite. So she's somewhere in between that. So if we're looking at a functional position for her, you could get away with just doing, because she's like narrow and deep, you could do like a composite pad type of thing, set her up ortho-wise, and get her into this as long as we keep muscles under control. This is a periodic. It doesn't do it every time. And that may be just that bite coming in place there. But it dropped down to 18.686. The big spike right there is that she's hitting one side harder than the other. So it torques it just a little bit when she goes to closure. That could be adjusted. I don't have a burr, I don't have a handpiece, but that could be adjusted. But when we look at this, it's in the ballpark range. But it's a functional. We go functional position with her and say, well, we could restore her somewhere between that phonetic phase and an apex phase, and move things around ortho-wise, level her occlusion back out, and still keep and hold on to disc from where she was before when she was, on her initial JVA was 300 something. Oh, yeah. So from a 300 something down to this, and you're accommodating where a functional spot would be, this would be dynamite. So you can check it and test it to make sure that, okay, now we could go through and do the treatment we need to get her out. Because do you want to put glass in all your teeth? Do you want to wear an appliance your whole life every day? You're not into denting anywhere. So this would be a case where I would say she's already been orthoticed out, where her disc recaptures and stays on pretty easy when she wears her appliance. I transition her into an ortho type of a situation and hold this position with composite pads and a turbo up front, and then move teeth around it, and then recheck it as she goes through, and adapt your position, your AP and your vertical position as it goes through, because it's totally recapturable and totally holdable by going through two different methods. By going through phonetic method or going through an apex of force method, you can keep this disc captured. And when you look at that, you say, well, what's the easiest treatment to do? What's the least amount of AP change movement you do to still hold onto the disc? And that's where you want to try to go for. But you measure it through the process to make sure you're holding disc and holding it in relationship so she's not continuing to blow out. So, and when you don't wear your appliance, you get like wicked muscle pain. Yeah, yeah. But that way she could wear something. She'd have some vertical correction, AP correction going through ortho. Cool. Okay. Questions about that? We're over time. I know it's cocktail hour. So if you can reach me by email, or I'll be here all weekend also if you have questions about anything. But